Hi everyone. We're going to get started. Welcome to the third and final day of the Strengthening Accessibility and Inclusion Within Professional Programs Conference, hosted by the University of Toronto Accessibility Offices. I'm Annika Stabino, the Experiential Learning Accommodations Coordinator at Accessibility Services at the University of Toronto. I'm a white woman in my late 20s. I have short brown hair and brown glasses, and I'm wearing a white shirt with blue ocean creatures on it. My background is blurred. Next slide, please. So now I'm going to do an access check. So we understand access to be a shared responsibility between everyone in this space. We will strive to create an accessible space that reduces the need for you to disclose a disability or impairment for the purposes of gaining an accommodation. In doing this together, we strive to welcome disability and the changes it brings into our space. Is there anything about the virtual space that we should address now? Are there any other access needs that might affect your participation in the workshop that we could address? On the next slide, we will go over how you can submit a response to either of these two questions, as well as for the rest of the conference. Throughout the conference, all speakers will describe visual elements as best they can. We welcome participants to turn off their cameras, get up and move around, and take as many screen breaks as they need throughout the conference. This slide shows a visual of the Zoom control at the bottom of your screen. Use the Q&A to submit questions for the presenters, or if you experience any technical difficulties and require assistance. You're able to submit questions anonymously. If you prefer to ask your question live, you can use the raise hand feature and you will be asked to unmute yourself. For keyboard users, you can use Option plus Y on Mac or Alt plus Y on Windows. For mouse users, select Participants, choose Raise Hand at bottom of the panel. We respectfully request that you wait until the designated question period to ask questions using either the Q&A or Raise Hand feature. Note that moderators may not be able to get to all the questions. We also have a sign language interpreter for the entire conference, which is available on laptop and desktop computers. Please submit a question via the Q&A feature if you are experiencing any technical difficulties. Next slide. So now I'm going to present the agenda for the third and final day. We're currently in the greeting, access check, and land acknowledgement portion of the day. Then from 8:55 to 9, we have an introduction to our keynote speaker, Dr. Kevin Stoddard. From 9 to 10, we will hear from Dr. Kevin Stoddard and his keynote address, Understanding and Meeting the Needs of Autistic Students in Professional Programs. We will have a break from 10 to 10:15. At 10:15, we will have our adaptive technologists, Ann Thomas and Lake Porter, as well as our health, mobility, and sensory team lead, Michelle Morgani, talk about adaptive technology in professional placement settings, followed by a student snapshot, my lived experience navigating adaptive technology and post-secondary education as a student with a disability, where PhD candidate Jessica Chakoff will share her experience navigating multiple degrees with a disability. We'll then have lunch from 12:15 to 12:45. Next slide. At 12:45, Dr. Pearl Levy and Dr. Tony Pignatello will present on clinical sites, academic programs, and accessibility offices, roles, responsibilities, and best practices in working together. At 1:45, we will hear remarks from Heather Kelly, the Executive Director, Student Life Programs and Services at the University of Toronto. We have a break from 2 to 2:15 before our final session, Fostering Inclusion for Physicians with Disabilities, with Dr. Michael Kwan and Dr. Camille Monroe. At 3:15, Vern Ross, a traditional knowledge keeper, will host an Indigenous closing and reflection with Michael Nicholson, the Director of Accessibility Services at the University of Toronto, St. George campus, will bring us to a close. Next slide. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. When reflecting on the land acknowledgement, I think of the places I've lived and worked and the immense privilege I've had to be able to move freely throughout this country. I grew up in the province of Nova Scotia. I attended university in New Brunswick. And it wasn't until I moved to Toronto that I learned more about the land where I was raised and the history of the Mi'kmaq, the home of the Mi'kmaq people. My childhood was spent enjoying the water and the land around me, and I'm so grateful I had the opportunity to swim and sail and appreciate the area in which I was raised. but I was never taught about the history of where I grew up. I was never taught that the names of the towns, parks, and bodies of water originated from stolen language, a language that for many years was forbidden to speak within the Shubenacadie Residential School and was discouraged throughout the province. I'm privileged to have access to this information through online courses, books, and films, but I'm disappointed I am only just beginning to learn and educate myself. As I learn more, I will continue to question and disrupt the impacts of colonialism that remain embedded in our system and structures. We need to do better. Next slide, please. And next up, I will invite my colleague, Jennifer Stewart, to introduce our keynote speaker.
Thank you, Annika. Good morning. My name is Jennifer Stewart. I am the intake coordinator and team lead at Accessibility Services. I am a white woman in my late 50s with shoulder length silver hair that is curly, and I'm wearing glasses and a black and white shirt. My Zoom background is my office. I am honored today to be introducing Dr. Kevin Stoddart to you all this morning, who will kickstart day 3 of our conference. Dr. Kevin Stoddart is founding director of the Red Path Center and adjunct professor, Factor Inwintosh Faculty of Social Work, University of Toronto. He has worked in the fields of autism, developmental disabilities, and child and adult mental health. Since the 1990s, his clinical focus has been children, youth, and adults with Asperger's syndrome and the coexisting social and mental health problems that affect them. He is an active clinician, seeing about 150 people and their families yearly. Dr. Stoddart's research and publications center on the clinical and psychosocial needs of autistic people and their families. He edited the first Canadian book on Asperger's syndrome entitled Children, Youth, and Adults with Asperger's Syndrome, Integrating Multiple Perspectives in 2005. His second book, with Drs. Burke and King, entitled Asperger's Syndrome in Adulthood, a comprehensive guide for clinicians, was published in 2012. He received the Queen Elizabeth II Diamond Jubilee Medal in February 2013 in recognition of his contributions. He is active in many research studies exploring topics including the presentation of autism in adults, aging in adults, marital relationships in families affected by autism, services for affected individuals, and social inclusion. His third book, In Progress with Dr. Fudge Sharman, discusses the role of social work in the lives of individuals with autism and developmental disabilities. Dr. Stoddart is on the editorial board of Autism in Adulthood and co-chair of the Ontario Working Group on Mental Health in Adults with ASD. Please join me in warmly welcoming Dr. Stoddart.
Good morning, everybody. Could I have the first slide, please? I want to focus today on understanding and meeting the needs of autistic students in professional programs. Next. Our objectives today are 4 in number. First, I'd like to review the current understanding of autism as it relates to adults in Canada, discuss our clinical experience at the Red Path Center with autistic individuals in professional programs, and some who have gone on to occupations in the professions, and the types of problems that they experience. Third, I'd like to share with you some solutions that we found in the amelioration of these challenges. And finally, provide us some opportunity for discussion and questions. So I'm hoping that about at 1:45 or 22 today, we'll have some opportunity for discussions and questions. I'd like to express my appreciation to my colleagues, Dr. Jason Manette and Dr. Vicki Nolan, Sarah Southey, Deborah Finkelstein, at the Red Path Center for their valuable contributions to this presentation. Next. It's important to realize that the landscape of autism has changed considerably over the past 20 or 30 years. We now know that the prevalence of autism in adults in the general population is at least 2%. Although we have limited data to base that on, that is our best estimate at this point in time. Since the early 1990s, we saw increasing numbers of diagnoses, primarily in children and youth, because we then began to understand that the autism spectrum includes so-called more able individuals with high intelligence and good language skills. So they're less affected by the symptoms typically associated with autism. This higher functioning group are increasingly being diagnosed prior to, during, and after their post-secondary education experience. However, it is really important to note that not all individuals are diagnosed with autism before university, and for those that are diagnosed, some of them are poorly assessed. Unfortunately, the service landscape has not changed to accommodate the needs of this specific cohort. For example, in Ontario, we are still struggling very much to meet the needs of children and youth with autism, and many tens and thousands of children and youth are still on waiting lists to receive assessment services and support. Services for adults remain very limited. Government funding agencies continue to be responsible for primarily children and youth, and those with more significant developmental delays. There are currently no funded services and supports for many of the university students that you will encounter who live with autism. Our helping professions' autism knowledge also remains very limited. So medicine, social work, psychology, these all, this limited information results in marginalization, stigma, poor mental health, and poor psychosocial outcomes for the students that we are seeing. This lack of knowledge in professions and helping professions has implications for educators in these professional programs and the students seeking help. Next. I'd very briefly like to review the diagnostic criteria that we use for autism. I must apologize for some of the language used in these slides. This is directly from the Diagnostic and Statistical Manual, and this is the language that is used to diagnose individuals across the lifespan with autism. We're really looking at major difficulties in social communication and social interaction. And this is the core feature of autism. And these problems occur across multiple contexts throughout an individual's life. We're really needing to identify social emotional reciprocity, thinking about failure to engage in normal back and forth conversation, problems initiating or responding to social interactions. We can begin thinking about how some of these characteristics might affect the students that we support. We're also looking at problems with nonverbal communicative behaviors. So we may have poor eye contact, poorly integrated verbal and nonverbal communication, problems with body language, deficits or in understanding and use of gestures, to a total lack of facial expressions and nonverbal communication. Finally, in the social realm, we see problems developing, maintaining, and understanding relationships. Individuals with autism, even very bright individuals with autism, may not understand social relationships and basic ingredients of social interaction. So it shouldn't surprise us that even very, very bright autistic people have difficulty understanding the basics of social interaction. Many of these very bright individuals have received little or no intervention in order to help them understand and repair some of their social behaviors and gain new social knowledge. Next. The second main cluster of features that we're looking at are restricted, repetitive patterns of behavior, interests, or activities. And we're looking for 2 out of 4 of these criteria. We're looking at repetitive motor mannerisms, use of objects, and particularly for the group that we're talking about, repetitive speech. There can be insistence on sameness, inflexible adherence to routines, ritualistic verbal and non-verbal behavior, real difficulties with small changes, and sometimes considerable distress with those changes. We see highly restricted interests, and they may be abnormal in intensity or focus. Often, it's these very interests that lead our students to pursue the particular subjects and academic paths that they're so passionate about. But they also need to understand that other individuals may not be interested in the subject matter that they are so passionate about. So they need to learn how to have conversations about other things, like things that other university students might express interest in. Fourth, and maybe most importantly, and this is quite unique to autism, is this hyper or hyporeactivity to sensory input. And that may result in unusual interests, and it can also be a problem in various environments. So for example, we need to understand about the influence of a noisy hospital ward or emergency unit. We need to understand the effects of sitting in a lecture hall with bright noises or fans running all the time. We need to understand the effect of echoes and hard surfaces, which can impair our ability to process information in an auditory way. Next. So this is a Venn diagram that illustrates that we have multiple coexisting conditions along with the core features of autism. And I'm going to stress that we need to identify accurately and precisely identify each of these coexisting conditions in order to successfully help the student who is autistic in professional programs. So we know that anxiety and depression are very common in individuals with autism. And I'll show you some statistics from our study several years ago that relates to the frequency of those diagnoses in this population. We see sensory and perceptual differences. We see cognitive strengths and weaknesses, just as we might in other students we support. We see problems with attention and focus. We see a cluster of individuals that really struggle with other mental health problems. For example, we know that women on the spectrum may really suffer from eating disorders which are not well addressed. We may also see obsessive compulsive disorder or traits of OCD in many individuals on the spectrum. We're now understanding that there are a host of medical conditions as well that are more likely to occur in somebody diagnosed with autism. Some of these include breathing problems, allergies, gut problems, digestive problems, and neurological issues. Next. And most importantly here, we have challenges in understanding that life skills can be a huge issue and a huge problem for people on the spectrum. So again, just because somebody is gifted, has done extremely well in their area of study, in their academic programs, does not mean that they're equally competent in their life skills. And in fact, the development of life skills and training around life skills is often overlooked in these highly intelligent, gifted people who may or may not have been diagnosed with autism. Next. So in our study almost 12 years ago, we looked at a community sample of individuals who had been diagnosed with autism. And I want you to remember that this is a community sample. And it was 480 individuals represented in the study. And we asked them about their mental health diagnoses. So the numbers at the bottom of the slide are percentages. And you will see that by far the highest, most frequent diagnosis was an anxiety disorder. That's at 45%. Again, this is a community sample. So if we were to think about the sample being a clinical sample, for example, those that we see at the Red Pass Center, that number might actually be doubled. We see probably 85 to 90% of people who have been diagnosed with an anxiety disorder within the past few years or have struggled with anxiety. So the second most common diagnosis is depression. Then we see learning disabilities, attention deficit disorder, obsessive compulsive disorder, and sensory integration problems. So those several diagnoses are certainly, and the frequency of those diagnoses are not a surprise to those of us who daily speak to those on the autism spectrum. It's also important to notice that bipolar disorder, Tourette's disorder, eating disorders, personality disorders, and psychosis or schizophrenia are infrequently diagnosed for people on the autism spectrum. And there continues to be quite a bit of misinformation about the connection between schizophrenia, for example, and autism. Those with autism are no more likely to have a thought disorder or schizophrenia than those in the general population. So when you're seeing students, we really want to focus on those traits, those mental health characteristics that are most frequently diagnosed in the population of interest. We also have a difficulty with the diagnosis of mental health in autism, and that difficulty is called diagnostic overshadowing. So many people who have these mental health struggles are not diagnosed with them because well-meaning physicians, psychiatrists, psychologists feel that some of those symptoms are a part of, if you will, their autism. And that results in problems with treatment, problems in their academic process, when we can't kind of tease out the mental health problems from autism and apply appropriate evidence-based intervention for those specific problems. So that's very, very important. Next. Some common reasons for intervention for this higher functioning group. Again, poor social skills, poor insight into social interactions, inability to effectively communicate. We might also think about various ways that a student needs to communicate in the course of their time at university. They may monopolize a lecture. They may monopolize a group situation or conversation. They may sit quietly in a class. They may find it hard to initiate a communication with a professor through a text or through an email. Problems identifying, understanding, and expressing emotions. Sometimes individuals with autism, in the absence of an ability to understand others' emotions, may feel that people think negatively about them or feel negatively about their, for example, participation in class. Sensory processing differences we've talked about. Somebody may avoid going to a class or going to a meeting because they're avoiding a sensory situation that is uncomfortable or distasteful for them. Students with autism have poor executive functioning and organizational difficulties. Obviously, this is something that we see across many students that we support in accessibility services, but this is a significant problem, especially if the individuals have achieved good grades and good academic standing in previous courses or in high school. They have not learned basic organization, planning, execution skills. And this is a major activity of many coaches here at the Red Path Center to assist them with those processes. They may learn idiosyncratically. They may have difficulty processing and with output. They may need multiple sources of information at the same time and at different times. They may have restricted and repetitive interest-related behaviors, which might relate to course selection, which might also relate to academic failure in courses that they're not interested in or not motivated to complete. They may have problems with emotional regulation, problems with fine and gross motor development, which necessitates the use of a computer or voice-to-text software. They have difficulty navigating life transitions. If they're in their early 20s, coming to University of Toronto or another city, this is a scary process, and they may lack basic life skills in their own community, let alone in a new and strange community where their academic program is. They have problems with changes. This is a core feature of autism. And this also relates to having an inflexible cognitive style. And finally, very importantly, a long-standing failure to make and maintain interpersonal relationships. So many autistic students do not have the benefit of close peer support while they're going through the program. Group projects may be extremely difficult for the autistic student, and just the chit-chat about problems and difficulties in particular courses or the program is really not available to the student with autism. While other students may have that form of support, they do not. Next. So we're really beginning to understand that autistic adults need a range of connected, multidisciplinary services and supports. And it's important for each of you in your academic settings to engage with community members and individuals, professionals who are able to provide these kinds of supports. Because often as accessibility providers, for example, you identify a need with a client that they need social skills support, or they need to be addressing their anxiety about performance, etc. And we need to kind of be developing a plan for students with autism to connect with local supports. Students with autism are coming to your programs and will continue to come in increasing numbers to your programs. So I would challenge you, each in your own program, to have a plan, have a list of resources that you have vetted that are very knowledgeable about autism and the comorbidities which students with autism face, and continue to create that list in your ongoing work with students. So we're looking at many services and supports here: individual therapy, therapy through medication, psychoeducation about mental health and self-care strategies. Sometimes we need to be engaging in family therapy. We see couples here where one or both individuals have autism, and we need to discuss their language and problem solving and sometimes co-parenting. Occupational therapy might address the sensory needs of individuals on the spectrum. We have behavior therapy and coaching, and the coaching is really the nuts and bolts of the service and supports that many students with autism benefit from. There's a large case management role, and sometimes accessibility providers are tasked with managing the students' various services and supports, both on campus and in the community. Many students struggle with understanding their future employment, and those issues might be raised during a professional program, but also, of course, towards the end of their program as they're leaving the program and entering the workforce. We have social support and psychoeducational groups. There are support groups, many on campuses at University of Toronto and York University, for example, that I know of in Toronto. And these are important kind of touch points for students to engage with other autistic students and discuss their experiences in their programs and in their academic life. Academic advising is obviously an important ingredient to the treatment plan, and in some cases, rare, but in some cases, we need to have a discussion about inpatient treatment where harm to self or others is a concern. Next. So I really want to turn now to the specifics of meeting the needs of autistic students in professional programs. First, I'd like to start with a case example. A medical student was referred because of multiple problems relating to their profession, because of multiple problems relating to their professionalism. And I'll talk about that word professionalism in a minute. Those problems involved seeming rude or curt with colleagues in the program, failing their OSCE, their objective structured clinical exam, and monopolizing discussions in class. The program provided feedback at various times, but primarily at the end of the term. And feedback was also provided by teaching staff at the local hospital. But again, this tended to be at the end of rotations. What was shocking was that the student had excelled in their undergraduate program, and they were considerably anxious and surprised, feeling hopeless that they were doing so poorly when that came to medical school. The student lacked insight and awareness of their poor interpersonal skills, had really not received any support, social skills interventions at all throughout their life. They did not understand their ability to process constructive feedback and the effect of anxiety on the processing of that feedback. So they would respond tearfully, angrily, leave appointments where they were being given negative feedback in person, and be incredibly upset when they received feedback by email that was seemed to come out of the blue for them. So the student was asked to complete a remedial year with the support of a clinician, and the physician health program through the Ontario Medical Association was involved. The school and the program, of course, was involved, the accessibility provider. A mentor was established. Community physicians also supported the student, and all of these individuals had a greater understanding of the student's challenges, including the fact that they had come into school with an autism diagnosis. And this, in part, was not the case when the student entered medical school, and in part created many, many challenges for the student and for those who were supporting him. Next. Briefly, we need to think about the essential role of accessibility counselors. So on intake, I can't emphasize this enough, We need to ensure that there is a comprehensive and recent assessment on file. The fact that they've had an assessment even a few years ago that have confirmed the core features of autism is not often sufficient and not setting up the student or those who support them for success. We need to understand their learning profile, which is often included in assessments. We need to understand how they do best with output, and often written output. However, we also need to understand very clearly what their executive functioning profile is. Do they have problems with organization? Do they understand what's required for a task? Do they come prepared? Can they start an assignment? Can they start a period of study? Do they spend too much time studying? Do they understand the need for breaks? Do they understand self-care and other things like exercise and eating well in a period of high stress, potentially at the end of an academic term, for example? What is the role of sensory issues? How can sensory issues and a good sensory diet be a part of their self-care plan? What are their mental health issues? How well have those been assessed? Quite often, students will come in and acknowledge that they suffer from anxiety or depression, but have no real plan in place to address those. And that reflects the huge problems in our mental health system right now in being able to support autistic adults with mental health issues. Again, attention and focus. There may be awareness that attention and focus are a problem, but not any strategies in place, and not any tools in place to help them with that. And then there's the issues of activities of daily living. Obviously, a student who is coming to a residential setting is faced with many, many new challenges, including finding healthy food, self-care, washing clothes, getting to bed on time. Again, many of these basic activities of daily living are struggles for people with autism. So the accessibility counselor needs to provide appropriate community resources for diagnosis, coaching, and therapy. Again, I want to emphasize many students that are coming to professional programs are not well assessed, and some will not have been diagnosed with autism when they meet diagnostic criteria for autism. You need to assist the student with administrative aspects of their life, advocate for the student when they require access to accommodations or a new accommodation. We really need to assist the whole team, assist the student in determining the game plan for the academic year. What is the game plan? What is the plan around reduced course load? When do we talk about dropping a course? What academic supports need to be put in place? Or do they need organizational supports or social emotional supports? The key here is really preemptive planning. So discuss with the student potential problems that they've had in past programs, strategies that they use to address those, and how those strategies may play out in the current academic year. What are sources of new challenges or problems with this program and with this setting? And how can you plan proactively to address those? before you're in the midst of the stress or the problem. Next. So the primary reason for referrals of students or professionals, we see many professionals who are having problems in their work lives. The primary reason for referrals is difficulties with interpersonal and social skills. Not surprising. These problems may be recognized with other students, for example, in classes, by professors during their OSCEs or internships. Many students may actually make it all the way through their program and get to the internships and then have incredible stress and problems when it comes to interacting with a patient, for example, or interacting with many staff or colleagues that are new to them. A determination needs to be made as soon as possible if the skill problem are within the school's scope of expertise, meaning do they relate to the profession's practice skills, or are they more pervasive? Is there an idea that this student has interpersonal social problems that have affected their participation in classes, their interactions with professors previously, potentially their interactions with other people on campus? If they're more pervasive, then the program, the accessibility counselor, maybe even the individual in charge of internships and placements need to work together to find outside resources that are going to be helpful and expert in helping the student. Often, as I've said, we don't know that somebody has autism. Sometimes their diagnosis is not disclosed to a program. Of course, I encourage all of our students to disclose the autism diagnosis to the accessibility provider. However, that means that in most cases, the professionals, the professors that the student is interacting with may not know the diagnosis. Maybe the student does not want to tell their mentor that they have autism. So there's variable knowledge in most cases about the presence of an autism diagnosis when it does exist. A real concern for those of us who have worked with students in professional programs is the pathologizing response that programs have had to their difficulties. And in some programs, we've seen phrases like lacking professionalism. And this is of course, very inappropriate and hurtful for the student that is naive to some of their social problems, naive about how to fix them or remediate them, and is a real blow to their self-esteem and their hopes and dreams about the future. So we need to frame difficulties with social interaction in different ways, in more specific and helpful and less pathologizing ways. As a result of phrases like lacking professionalism, a student understandably will become anxious or defensive or unable to follow through with suggested remediation. The student, the program, the placement, accessibility services may all have different understandings of problems. They may or may not know that problems even exist. And I've said here that the student may be suffering in silence due to their lack of peer connection or support in the community. It's also important to know that in stressful times, these social problems might be exacerbated, and other behaviors may be triggered in the absence of appropriate social and clinical supports. Next. I think we skipped one slide there. Okay, so there are some problems that occur related to comorbid issues as well. Obviously, learning and adapting to multiple new settings is a problem, and needing to do that in a short period of time is stressful. So again, we need to rely on preemptive strategies. The student needs to visit the campus on weekends. The student needs to visit the campus during the summer. The student needs to be there during the first week of orientation and engage in orientation. They need to be running through their class schedule throughout a week and finding their way to various classes. So this is really about learning the physical environment. I've talked about that. They also need to understand social norms and specific processes in practice settings. So what are the standards around dictation and charting, for example? How do we function in this particular setting? And differences between one setting and another can cause great distress and confusion. So again, just because the student is obviously very bright and very good at the substantive knowledge of their profession does not mean that they're going to understand social norms and specific processes on particular placement sites. Feedback to autistic students must be specific, ongoing, and concrete. And I always encourage students to begin to get feedback from the start of their program, from the start of their courses. If we can have weekly assignments or weekly tasks in a course where they're getting a grade, where they're getting feedback, that is much better and much less stressful than having one assignment in the middle of a term and one at the end of term. In placements, we need to be giving continuous feedback to a student, the things that they're doing well and the things they're not as successful at. We often are hearing that programs are giving feedback mainly when the student is at risk of failing the placement. And that is not setting the student up for success or the program up for success. What are potentially problematic gaps in the student's daily living skills? Do they have problems making appointments? Do they have problems with drug and alcohol consumption? Is sexual safety a problem? Is taking their medication on a regular basis a problem? All of these issues need to be addressed in some way with an accessibility counselor or with supports and services external to the university or college. What are the executive functioning problems? These need to be explicitly explored through standardized measures such as the brief. It's not just enough to know that a student has problems with organization and planning. We need to do a deep dive into those organization and planning problems and respond accordingly. What are the sensory problems and strategies that are idiosyncratic to the learning environment? On a psychological level, a student who is experiencing problems in a professional program may be connecting their current problems to their educational past and those times when they were not understood or accommodated or even punished by some of the behaviors that they engaged in. So it's really important that we keep that historical lens of the student's life and academic career as much as possible, as much as is appropriate, because that is the lens with which they're viewing their current academic problems and situation. Again, and finally, what medical conditions are affecting performance? We see many people with GI issues that are not well managed, and they're struggling with issues like IBS and Crohn's. Diets tend to be very restricted for some people. There are students that are eating only fast food or eating only cafeteria food. And although we've made some strides in terms of access to good diets on campuses, there still is and continues to be lots of problems with food intake and basic self-care, including sleep. Next. Work on social cognition is a long-term endeavor. And we know that many autistic individuals will not have the insight or knowledge that they are lacking in these areas. So we need to engage psychotherapists, behavior therapists, and speech language pathologists. Mentors within the professional faculty can be assigned to assist with performance issues. External partners, such as the OMA's Physician Health Program, can assist in referrals and determining appropriateness of certain supports and services within the community. Often, problems in professional programs raise issues around the student's vocational path and goals. We need to have that discussion about whether or not this profession is suitable for them. Can their social and interpersonal impairments be remediated for the purpose of work or the chosen area of practice? Ongoing assessment needs to occur with respect to the contributing factors. We've talked about those things. In all cases, it's helpful to use concise, written, and measured and specific feedback as soon as is feasible for the student and the program. Next. Some other solutions: acclimatize by going to settings early. Utilize varied teaching practices, explaining, modeling, shadowing, observing. Supervise while completing expected tasks, then they attempt on their own. Adjust shift length in hospitals or internships. What is the frequency, duration of placements? Can we have shorter placements? Can the student have a placement in a different unit in a hospital that they're more familiar with than having a placement or rotation in a different hospital where they don't know the people and the policies as well? How can we identify optimal learning processes? When does the student learn best? How does the student learn best? We can apply those, and then we need to reassess those learning processes. So we might understand this as needing to master a skill in an ideal situation, whatever that means for the student, and then increasing expectations or complexity. We need to utilize a mentor or mentors who understand the specific environment or dynamics at a learning site. And that mentor can be a source of debrief or immediate feedback, as well as emotional support. In terms of clinical interviews, we need to develop templates, possibly with mentor support, to use during patient interviews, so that the individual is focused and goal-oriented and following a process in a patient or client interview or interaction. Finally, we need to consider how essential some so-called essential requirements are for a particular student. In this case, I think of a pharmacy student who couldn't pass because of a mandatory rotation doing customer-facing work at a pharmacy. His interests, however, were all lab and research-based. He did not want to work in a pharmacy setting. So that program needed to kind of adapt some of their so-called essential requirements to this particular student so that they could graduate and move on to the type of work in the occupation that they wanted to work in. Next. So very briefly, I want to leave you with some information about the Red Pass Center. You can look that up on our website, or redpasscenter.ca. We are providing services primarily in Toronto, but also across the province of Ontario. I'll leave it at that, and we have about 10 or 15 minutes for some questions.
Dr. Stoddard, thanks so much for that presentation and overview. That was some really great content, and I think it resonated a lot with the folks on this call, so thank you. We have a few questions here. So one is, how do you address the timelines for assessment when a student is in a program, but the wait list is 23 months or more for an autism assessment?
This is a very challenging situation. We in fact have a fairly long wait list in Toronto here at the Red Pass Center. I think that whoever is advocating for the individual or the student needs to make a case for an urgent assessment. And even if the individual does not have a formal diagnosis, they can still benefit from services and supports from a provider, such as a coach or a counselor that is familiar with ADD, learning disabilities, and autism. So ideally, the assessment would come first, but sometimes that's just not possible.
Great, thank you. We have a few more questions here. So one is, or it's a couple parts. So what would you suggest a program or accessibility office do when a student fails a practicum or placement due to this aforementioned professionalism that you were speaking about? Often there is a bit of a roadblock between faculty and accessibility services, as the program will talk about, quote, not meeting essential requirements or competencies. And yet we understand that this student's way of communicating is related to being neurodivergent. So how might we deal with this roadblock?
Well, I think it's important to understand that professional programs cannot remediate some of the issues that we're discussing on their own. We need to bring in external professionals, consultants, advisors to understand what exactly the problems are and what coaching or counseling or supports they need. Then they need to go back into a placement or an internship where there's awareness created of the students' challenges and difficulties and a plan to support them with those. So looking to external supports, good communication between support systems, silos, I would call them, developing a proactive plan with eyes wide open to address the problems in a collaborative way with the student and with community professionals.
Yeah, I would also assume that, this is just a personal comment here, but I would also assume that ensuring that practicum offices maintain good communication with those practicum sites so that they aren't getting to the point of failure, and that there's communication throughout so that if there are concerns around professionalism, that might be addressed and intervened during the practicum, right?
Absolutely, absolutely.
So there's some other questions here. One is again back to assessment. So where can you refer adults concerned about the wait list and the cost? What has been challenging in terms of assessment, and what contributes to the long wait list?
What contributes to the long wait list?
Yeah, that's part of the question.
Okay, well,
yeah.
So I think this goes back to our, fairly recent understanding, acknowledgement that autism does not end at the age of 18. I'm not being sarcastic here. This is the belief in our system that magically somehow autism stops at the age of 18. That is what our system reflects. So along with that, we have clinicians who are not trained to diagnose autism in adults, who, many clinicians, me included, first worked with children and then realized that there was a tremendous need for transitional age youth and adults, and have moved into serving primarily adults. And that continues to happen. We're making efforts to engage more physicians, more psychologists, social workers in discussion of autism in adults, and that's an ongoing work. And I really do appreciate the opportunity to speak at this conference and highlight the needs of autistic adults. But we need to be doing better in multiple schools, medicine, social work, psychology, in addressing the tremendous need for diagnosis and assessment. Unfortunately, there are very, very limited resources that are OHIP covered. So we might see diagnosis, a cursory diagnostic statement made if somebody is an inpatient in a hospital or is being followed by a psychiatrist in a medical setting or a hospital. Often we're kind of surprised by those diagnoses. The source of funding really often comes from the OSAP bursary, and that's been incredibly helpful. So I really want to reinforce the usefulness of that OSAP bursary, not only for getting an assessment, but for ongoing coaching, academic, social, emotional coaching, and counseling throughout the students' time.
Yeah, I think many of us on this call can speak to the value the bursaries provided for our students who otherwise would not be able to access those resources. So just a couple more questions here. So to what degree does educating the public, so employers, academic departments, et cetera, help in mitigating the tensions you described for the person with autism navigating those places?
Absolutely, right? We need to continue to change the discussion from, children with autism to, individuals with autism, and understand that autism is a lifespan condition and issue. We're beginning to see some very nice movement with some major employers in terms of their awareness of neurodiverse applicants and employees. We continue to need to make inroads through education and training and support of employers. Again, the general public as well, a good point, needs to be educated. We may all know people in our lives that show some signs of autism that are, very socially awkward or inappropriate, and are not succeeding in kind of day-to-day activities, are not being employed, or having multiple jobs and losing them. Why is that occurring? We need to kind of be understanding the need for assessment and supports in all of these situations.
Great, thank you. We have another question here. How would you approach working with a professional program student who might describe their primary concerns, whether it's in documentation or in your intake appointment, as related to ADHD, and is uninterested in or resistant to ASD specific supports?
Well, I think that we're increasingly seeing an overlap between symptoms of ADHD and ASD. So social work has a saying, and it's very important: start where the client is at, right? If they're resistant to further assessment or diagnosis, that's obviously their choice, and that's their position. But we can understand that there are some crossover problems with ADHD and ASD. So maybe to address those in the context of ADHD and move forward. Maybe the student needs some time to process other difficulties and challenges. There are lots of great blogs and firsthand accounts, and I often lead people to those to kind of really understand what autism in adults looks like, because there's so much misinformation out there.
Great, thank you. And finally, we'll just do maybe one more before we break. So do you feel that post-secondary institutions should be providing coaching support, or should it be outsourced?
I believe that both should occur. I think that there is a benefit to have coaching inside the institution, because individuals inside the institution understand how that institution works better than any external support. But there might be an external support that is more versed in the challenges of autism, ADHD, and LD, for example, and has more of a kind of a therapeutic role, as opposed to a primarily an academic coaching and support role.
Okay, that's great. Thank you. Dr. Stoddard, I just want to thank you so much for this presentation. Clearly lots of questions and interest in this topic, and I think it's, as I said, it's resonated a lot for folks, and I think all of us working in obviously post-secondary education are really seeing a lot of these issues and concerns come up, and certainly the need to understand that this phase of life is completely different for students. It's not just an extension of, public school or, the assessment maybe that they got in grade 3, and that especially in these professional programs, just really getting an understanding of the student's experience and the professional program content and requirements is so important. And it's great that Red Path is a place that we're able to look to for that support in working with our students. So we really, really appreciate you being here today. And just a reminder to everyone, if folks have questions or want to connect more with the Red Path Center, there's more information in the slides about that. And I just wanted to let everyone know that right now we are going to be moving to a break. We're going to be coming back at 10:15 to have the session on adaptive technology in professional placement settings. We do have a very, very packed day with lots going on and a couple back-to-back sessions. So please do take a break, stretch, get a snack, come back and join us at 10:15 for the rest of the conference. And thanks so much, everyone, for attending today. And thank you, Dr. Stoddart.
Thank you.
Hi, everyone. Welcome back from the break. We're going to move into our next session now, and I'll start with an introduction. So my name is Sezgi Ozel, and I use she, her pronouns. I'm an accessibility advisor on the chronic health, mobility, and sensory team. Most of the team that I work with is presenting this next session. I will be moderating now through to the end of this session on adaptive technology. I'm a woman in my late 20s with olive skin. I have long brown hair that's currently curled, and I'm wearing a blue floral shirt with a white button up on top. My Zoom background is of the Progress Pride flag. Access check, a shared responsibility. We understand access to be a shared responsibility between everyone in this space. We will strive to create an accessible space that reduces the need for you to disclose a disability or impairment for the purposes of gaining an accommodation. In doing this together, we strive to welcome disability and the changes it brings into our space. Is there anything about the virtual space that we should address now? Are there any other access needs that might affect your participation in the workshop that we could also address? On the next slide, we'll go over how you can submit a response to either of these two questions, as well as for the rest of the conference. So throughout the conference, all speakers will describe visual elements as best as they can. We welcome participants to turn off their camera, get up and move around, and take as many breaks as they need to throughout the conference. This slide shows a visual of the Zoom control at the bottom of your screen. Use the question and answer to submit questions for the presenters, or if you experience any technical difficulties and require assistance. You are able to submit questions anonymously. If you prefer to ask your questions live, you can use the raise hand feature, and then you will be asked to unmute yourself. For keyboard users, Option plus Y on a Mac or Alt plus Y on a Windows will unmute yourself. Mouse users can select participants, choose raise hand at the bottom of the panel. We respectfully request that you wait until the designated question period to ask questions using either the Q&A or raise hand feature. Note that moderators may not be able to get to all questions. To enable text captioning, click on Live Transcript and select Show Subtitles. Text captioning is auto-enabled on mobile devices. We also have sign language interpreting for the entire conference, which is available on laptop and desktop computers. Please submit a question via the Q&A feature if you're experiencing any technical difficulties. Next slide. So now I will introduce our speakers for today. for this session. First is Ann Thomas. Ann Thomas has a background in psychology and rehabilitation teaching and has been working in adaptive technology as an adaptive technologist in post-secondary education for over 20 years. She is currently an adaptive technologist in accessibility services at the University of Toronto. Lake Porter. Lake has been working in the field of adaptive or assistive technology for over 20 years in both developmental and service roles. Lake comes from AT from an interesting perspective, having been trained as a musician and also having a certificate in information management with a specialty in information architecture. One of Lake's formative experiences with assistive technology was developing the Sounds for Sun Microsystems audio interface for the swing set framework. And last but not least is Michelle Morgani. Michelle is an occupational therapist with 14 years of experience working in various educational settings, including post-secondary education. She's currently a team lead at accessibility services at the University of Toronto, focusing on chronic health, sensory, and mobility accommodations. Michelle has a keen interest in supporting students' academic success and providing fair and equitable academic accommodations. So without further ado, this is our session on adaptive technology in professional placement settings.
Thank you, Sezgi. So yes, welcome everybody. Good morning. So my name is Michelle Morgani. I am a Caucasian woman with dark brown shoulder length hair. I have olive skin and green eyes, and today I am wearing a sleeveless black shirt. And I do have a blurred background because I didn't know if you really wanted to look at filing cabinets this morning. So welcome this morning. So we are going to be discussing a review of some best practices around adaptive technology assessments and how we can best utilize adaptive technology to support our students who are engaged in professional placements in education. So I'm going to pass it over to Anne to start us off.
Thank you, Michelle. And we'll go to, I guess, the next slide, please.
I actually apologize. I forgot the agenda. So I'm just very briefly, Anna's going to start us off with some of the assessment tools. My apologies. And then we will talk a little bit about some clinical interviews and considerations. Lake and I will present a multitude of case studies that we can chat a little bit about some specific adaptive technology options. And then we will leave some time, of course, for some questions and answers. So next slide, and Anne, please go ahead.
Thank you, Michelle. Again, as Michelle mentioned, I'm Anne. I use she, her pronouns. I'm wearing a gray shirt and have long, mostly still dark hair and glasses. And I also have a blurred background. So for the first assessment tool I'm going to talk about today is the COPM, the Canadian Occupational Performance Measure. It was originally designed for OTs, by OTs, and it's become one of the most used outcome measure in OT. It's used in over 40 countries and translated into over 30 languages. It measures performance and satisfaction from the student's perspective. So first, it's used to identify issues of importance to students and then detects the change in their own self-perception of their performance over time. It's administered at the beginning of services, or in our case, before technology accommodation, and again after accommodation. Next slide, please. So the first step in the COPM is identifying the issues or challenges being experienced by the student in the practicum. And in this case, the more specific and detailed, the better. It sorts the issues into 3 categories of self-care, productivity, and leisure. But most of the issues identified in our cases will fit into the productivity category. So the student will rank the issues by importance using a scale of 1 to 10, and then select the top 5 most important issues to work on. Next slide, please. This is an example of a form for capturing the initial issues or tasks to be taken on. It's divided into sections, again, as self-care, productivity, and leisure. But When we're doing this work in a clinical placement setting, we might further categorize these tasks into more relevant subcategories, such as reading, documentation, organization, etc. And on the right-hand column, there's an importance rating for each task as determined by the student, and ideally we'll address those most important issues first. Next slide, please. Once we've determined and prioritized the issues of concern, it's time for the initial or baseline assessment. The student rates each of the top issues or tasks by how well they feel they perform on a scale of 1 to 10. With 1 meaning they can't do the task at all, and 10 performing the task perfectly. Then they then rate their issues by how satisfied they are with their performance on a scale of 1 to 10. 1 being total dissatisfaction and 10 being completely satisfied. And then a reassessment is scheduled for after the intervention or the technology accommodations are put in place. Next slide, please. Then the interventions or technology accommodations are arranged and put into place. So equipment is ordered and purchased, set up, any needed training occurs. And then after a set period of time with the accommodations in place, it's time for the reassessment. Using the same 1 to 10 scale, the student again rates their performance and satisfaction with regards to each of the issues that are being accommodated. Then it's scored, and depending on those scores, it may be necessary to modify or try out a new technology solution or move on to any new issues that arise over the placement. And the COPM can be repeated as more and more issues arrive throughout the program. Next slide. So part of the reason the COPM is so widely used is it's very easy to score. At the initial assessment or baseline, we can call that time 1. You just add the performance scores for each issue and then divide by the number of issues, and then you get an overall performance score. We do the same thing with the satisfaction scores to get that overall score as well. Then after the accommodations have been put into place, you reassess and do the same thing with the new scores. And then we call that time 2. So you can quantify the change that has occurred by subtracting your original scores, time 1, from time 2, your reassessed scores. And changes of 2 or more points are generally considered clinically significant. Next slide, please. So this is an example of a scoring card that's included with the COPM. So there's a series of columns across the top. The first column is the performance or issue or the task itself. Then we have the student's rate of importance or priority. Then we have the student's initial scores for perceived performance and satisfaction, T1. And then their scores after the intervention or accommodation, which is T2. From the next 2 columns are subtracting T1 from T2, so we get an overall change. And you'll notice in the final 2 columns, you'll see that after intervention, there was a significant performance of 3 overall, and after for performance and for satisfaction, that was 5.5, so even more significant. Next. So one strength of COPM is that it's goal-oriented. It can help the student self-reflect and may help students develop insight into their own strengths and challenges. It also puts the focus squarely on the student. The provider is a partner in the process, but the student remains the expert in the process. Challenges include that it only measures user satisfaction. The COPM relies purely on client report and perception, and some students may lack insight into their own performance. It's also not specifically designed for use in a clinical placement setting and needs to be modified in each setting in order to really be useful for the provider. Next slide, please. Another assessment tool that can be used is the SET framework. The SET is an assessment framework originally designed for use in educational settings. So it consists of 4 main factors: the student, the environment, tools, and task. So first is the student. Of course, it's the center of the process. What are the functional areas concerned? What are their strengths and abilities? What are their present levels or expectations? And these are kept broad to begin with, so we don't eliminate any possible solutions right from the beginning. Then comes the environment. And this is where we want to have as much detail as possible. Where is it taking place? What are materials and equipment being used? Are there any access issues? What are the supports and barriers, including attitudinal, that are present there? Then there's the task. So what are the specific things the student needs to do in that specific environment to reach expectations? And finally, there's the task. The tools. And that's always considered last. Of course, it's much easier to select a tool if you already have a clear idea of who's going to need it, where, and for what. So that's where we're looking at what's needed to achieve the task. Brainstorming tools, selecting ones that look most promising, performing trials, and then collecting data and evaluating. Next slide, please. Pictured here is an example of one of the early information gathering forms in the SET framework. It explores the current conditions relating to the student with a column to be filled out for each of student, environment, and task. And this would be completed by a variety of stakeholders to represent a variety of perspectives. Next slide, please. So the key considerations of the SET framework include, like the COPM, it's student-centered. We consider the student's needs first. Also, it's ongoing, it's dynamic. You can revisit the framework often as any of the factors, your student, your environment, your task or tools change over the placement. But unlike the COPM, it's more collaborative. It includes input from multiple perspectives and includes guides for both staff and supporters throughout the entire AT process. Next slide, please. The final tool we'll look at today is the MPT. The MPT, or is the Matching Person and Technology Model. It was developed out of concern for technology abandonment, specifically research that found that although a technology might appear perfect for a given need, it can be used inappropriately or even go unused entirely when factors such as personal preference, psychosocial characteristics, or needed environmental supports are not considered. So this model really focuses on the degree and quality of the match between the user and the technology being used. The set of 3 characteristics it looks at, similar to the others, are the milieu, which is the environment. And this is where the person and the technology interact, the person who will use it, and the technology itself. So each characteristic contributes positively or negatively towards technology use. Next slide, please. And next slide, please. There are 4 steps to the MPT process. First, it's writing down the goals, possible interventions, and technologies that may support them. Second is looking at current and past technologies that have been used and the associated degree of success with those. The third is choosing the appropriate tools for the match. And finally, follow-up. Is the goal achieved? Is there a match? Have there been any changes? Do we need to go back to the beginning? And next slide, please. The ultimate goals of the MPT match are first, like both of the previous models, that the technology match is driven by the user. Second, the degree of match between the user and the professional is considered. Third, that all external influences on the use of technology in the student's life are considered by the professional. And then fourth, any mismatches are identified and dealt with immediately. Thank you. And with that, I will turn that back over to Michelle.
Next slide, please. Thank you, Anne. So some of the information that we're going to share in this next section may be a little repetitive from other sessions over the last 3 days, but I think it really drives home the importance of the collaboration we do as accessibility offices, not only with our students, healthcare providers, but also the programs in which we are working with. So I do just want to acknowledge some of the other pieces that we are utilizing for our sort of our intake or assessment around technology. So the first piece we really do utilize is medical documentation. This comes to us from those who are the experts in the disability. So we do rely heavily on those experts to share with us the considerations and functional implications of various diagnoses, knowing that most diagnoses live on a spectrum. So what one student may look very different from another student diagnosed with a similar condition. So again, really relying on that component to sort of help guide the beginning part of our process. We're of course looking at the functional impacts, as I sort of alluded to, the importance of how will it impact that particular individual and how will that likely carry over into their education. Then we are, of course, meeting with our students and considering a lot of their own lived experience, because of course, we know the student at the end of the day is the expert in their own disability, as well as their own impacts and impairments, as well as their own strengths. So we really want to ensure that we are drawing home on a student's strengths as well as part of this process. So we know that if a student is now in a professional program, the likelihood is they've already completed some postgraduate work, and therefore we can speak to, and ask them some questions as related to previous academic experiences. So what worked and maybe what did not work. Did they use technology or assistive devices in the past? Is this something that we should be considering to carry over into a clinical placement? Is it something that we can modify? Is it something that would be allowed in such settings? So we want to make sure that we are, of course, reaching out and finding out if any of those pieces existed in the students' previous academic experiences as well, or in their current experiences. Of course, we want to speak to students about maybe past and or current accommodations and adaptations that they are using. Again, both in academics, but also in day-to-day living, knowing that at this time a placement is taking them not only from the educational setting, but bringing them into somewhat more of a directed workforce. So we do want to make sure that all of those pieces are also considered. And then lastly, ensuring that a student may want to talk to us a little bit about what their day-to-day activities are. So we're talking about ADLs, or activities of daily living, and IADLs. So what we are thinking about here is the instrumental activities of daily living. As well, when we were meeting with students, they may have already had some clinical placements already. There may be a period where, you know, we're seeing them after a failed placement. We may be seeing them at the start of practicums altogether. So we may be meeting students at various aspects of their education, and therefore asking some of these additional questions really help to drive what our next steps will be around their technology use. And then lastly, we of course are really engaging in the field of study. So we recognize that many professional programs can look very different. We recognize there's a huge range of those specific kinds of practicums. We know there are, you know, social work and medicine and dentistry and et cetera, et cetera, et cetera. So we do want to make sure that those pieces are also, of course, taken into consideration. Next slide, please. So I recognize, just to first and foremost reiterate, this is not a slide I expect anyone to be reading. I just wanted to bring forward a really great resource. It is a book called Disability as Diversity, a guidebook for inclusion in medicine, nursing, and healthcare professions. And in chapter 10, they had some really wonderful sort of leading questions that we could potentially use to help guide us in our student intake when we're meeting with. And some of these specific questions sort of look at things like what maybe worsens or exacerbates your symptoms of disability. Are there medical appointments and treatments that you may have to engage in during this practicum? Do you require any kinds of medications during this practicum in terms of functioning? Again, recognizing that some particular medications could have a cognitive impairment or a cognitive influence on the student. I do just want to draw the attention to question 6 as it takes us into our next slide, which is essentially around reviewing and pulling and collecting the information around the technical standards and competencies for each program. We recognize that this is the kind of the crux of our work, and where the collaboration really sits is to ensure that what we're thinking about in terms of accommodations do not impact or negate the core requirements of a program or the learning requirements of the practicum. Next slide, please. So again, we're looking at things around the program requirements, and this is where it's very, again, just reiterating what we've heard a lot of over the last 3 days, is the collaborative process between accessibility offices and practicum offices and departments. So we really want to think about what are the essential requirements. So a lot of times, and I believe we sort of alluded to this yesterday, with, you know, number of practicum hours that are required. So what is a student required to complete before they graduate? What are the outcomes and the essential skills? So again, we talked a little bit about this in previous sessions, so I won't get into too many details, but there are various essential skills and core requirements for various programs, and we want to be ensuring that the accommodations and the technology, again, meet those needs. What kind of charting and documentation is the student going to be required to do within that practicum setting? Again, is it electronic? Is it handwritten? Where can we again support the students in the best ways? And then of course the review of technical standards and core competencies. So not every program has this and not every university may have this, but where they are available, we have recognized as accessibility offices how very important they are to again allowing us to communicate with students, communicate with practicums, and again speak to the departments around what can and cannot be done. Recognizing that not every single solution is going to be a perfect fit for all students. And then, of course, we are thinking about sort of the environmental aspects of the practicum. So where is the location? Because that can be an influencing factor. What are the hours? What are those requirements looking like? Are they overnight shifts? Are they day shifts? Are they on weekends? Do they have a 12-hour day? Do they have an 8-hour day? Some of the physical barriers. So thinking through things like lighting, the noise, access to the building. Are there stairs? Are there elevators? Do they have to go into the community? Will they be in a hospital setting? So we're really trying to capture the actual environmental pieces here as well. And of course, we want to talk to students about their perceived barriers. What are the concerns? What might be a challenge when they go into various settings? And then of course, we're thinking about the pace. So how many clients or patients are they expected to see? What are the number of hours they are required in a day, which again is sort of keeping with the top where I indicated the number of clinical hours. And then of course, the record keeping systems at each site. So again, they might use different technologies. They may use different softwares. We want to make sure we're keeping those pieces into consideration. And of course, we're thinking through all of these aspects with relation to the students' physical, their cognitive, their behavioral, their social, their ethical, and their professional requirements, as well as their functional impacts again. Next slide, please. And then another sort of the last sort of component to sort of put all of this together is really connecting with the program. So again, really relating to the fact that this is a collaborative process. It is not one person making a decision. It's all of us collectively coming together to come up with an appropriate accommodation plan and use of technology that would be required for that student. So we can really draw a lot from the program practicum coordinators. They will be the experts in practicum settings and the experts in what the requirements may be. There may be times when we're actually connecting directly to supervisors on practicum sites, ensuring that the student is able to utilize the potential accommodations we have suggested. And then potentially, even if needed, connecting to practicum sites. And this may be done through our practicum coordinators, because there are some pieces around the tech that we do want to ensure, such as the IT department. So is there a solid internet connection if we need to use various technologies, such as things like a real-time captioner, or ensuring that there's a Bluetooth compatibility for a student to make electronic notes as needed. And then a few other sort of questions we can consider and take back as well as, have other students with disabilities completed a practicum at this site? And if so, how did it go? Let's get some feedback. Let's take, again, all of those pieces into consideration. And then, of course, there's always a very big piece here around, is the student safe, but as well, is it going to ensure that the patient in which they're working with or the clients in which they are working with are also safe? So ensuring that the accommodations are not putting any additional barriers or any additional stress on others. All right, next slide, please. So we're going to move now into some case studies. So again, we do welcome any questions or feedback at the end. If you are able to add anything into the question and answers, we are very happy to touch base. So if I could get the next slide, please. So case study number 1 is Jane Smith, and they are a third-year medicine student, and they are an inpatient, will be going into an inpatient pediatric unit. And I would also just like to preface all of these case studies that these are all fictional, and these are all been done with some student in mind or various students combined in mind, but to acknowledge that these are fictional student cases that we are going to be addressing today. So Jane is a student who is deaf and does identify as being a deaf student. They rely both on ASL, so American Sign Language interpreting, and written communication for all of their communication needs. One of their functional impacts that they have also indicated is the cognitive fatigue. And often that comes with the translation between ASL and English, and recognizing that many individuals who are deaf learn ASL as their primary language, and English is actually considered a second language. This student completed the COPM with our adaptive technologist, and their largest concern was, of course, verbal communication and connecting with clients and connecting with their supervisor. Their performance score was a 2, and their satisfaction was a 1. Next slide, please. So some of the considerations for this site is obviously understanding the noise levels. While this student is deaf, I wanted to just acknowledge that noise can actually still have an interference if you are using any kind of speech to text software. So we do want to be considering those components. Noise can sort of potentially the noise can actually sort of cloud over the captioning in any other ways if there are background noises. So we just want to be mindful of those aspects as well. And again, we're thinking of communication with the various players. So this particular student will be meeting with patients, their parents, because they are young, and other healthcare staff, as well as their supervisor. So these are some other, again, considerations for the student. And when they have interpreters, having an interpreter presence within the setting, and how that will look and how that will sort of depict the next steps for the student in their interactions with others. The hours of operation, which may not seem like a big deal, but we also want to ensure that interpreters can be made available. And oftentimes interpreters may not be available in those overnight shifts. So we do want to just be mindful of when the student would be required to be on site in this particular setting. Documentation as well is something we want to be considering as well, how the student will be doing their note taking, and what kind of environment they may require to complete their documentation, and how they will be also collecting case notes. And then lastly, the other piece is really thinking through the communication with their supervisor, how that will look on a day-to-day basis, and how that will look for their sort of weekly or daily check-ins. Next slide, please. So I just want to also acknowledge that the next few slides are a whole slew of accommodations that I will be honest, I got a little excited about with how great we can accommodate for students with hearing impairments in various settings. So not everything that I'm going to speak to will necessarily all relate to our student Jane, but I just wanted to acknowledge that as a starting point, just to ensure that we are all you understand my excitement about some of these accommodations. So we'll relate some of them to Jane, and then we'll just relate some of them as sort of general accommodations that can work for individuals with various levels of hearing impairment and deafness. So speech to text services are really quite wonderful in many capacities. So this can be anything from your automatic captions to real-time captioning, RTC, or CART services, which is communication access real-time translation. So these are where we want to ensure there is a quieter environment, again, so that it's not picking up outside noises or outside voices, so it can be as accurate as possible. Of course, we also want to ensure this is where a strong internet connection is really important, because we want to make sure that if there are captions that are occurring, that there is a good abilities for the student to be getting as accurate as possible captions, if we are not able to have a stenographer on site at all times. One of the really great things I think that came out of COVID is the remote access to some of these services. So real-time captioning can be done remotely through, various portals. And another really great, as you can see today, is how ASL interpreters can also be provided in a remote context. So I will say it's the one bonus to being in a pandemic for 24 months, is that we have sort of figured out some other ways of accommodating our students who have hearing impairments in a way that sort of has been working for many individuals. So moving into my next piece was sign language interpreters. So sign language and interpreting can be both done in person, and it can also be done remotely. So in the case of Jane, they would require ASL, and therefore we would probably ensure that they had an interpreter or two that was present with them during the duration of their placements, or that we had some capabilities to transition between interpreting and various speech to text services. There's also telecommunication relay services, which is essentially a way in which you can amplify telephone. They can utilize a Bluetooth connection to a hearing aid, as well as some video relay services. So there are some other options here, not necessarily for Jane in this pediatric unit, but again, just acknowledging that that exists. And then another piece is almost just written communication. So not so much a speech to text, but something along the lines of what I have posted here in the top corner, which is called the UBI Duo, which looks like two small little laptops and they connect to each other. And as I type a note, it is active on the opposite side for the recipient, and they can see what I am typing in real time. And they can then respond also through typing directly back to me, and I can see in real time. So there is the opportunity to communicate through written communication, even pencil to paper. So very low tech as a solution, but to know that low tech is still an option in this particular case. Again, in the setting of being in a hospital for our student, the idea of having a text or a pager of some sort that may vibrate to obtain the student's attention, and therefore be able to provide them with some text options in terms of what they need to do in terms of going to another patient's room or to engage with another healthcare professional. And then we also have the iPads and or tablets that also have speech to text options in them. They also have an opportunity too, where again, I've utilized this with students in the past. They can type onto the screen, hold the screen up and show the text to another individual so that they can read it, and they could also do a type back or actually speak into it, have it populate back. So similarly to the bottom icon where it says ready to transcribe, these are some options that are even available on cell phones where you can actually speak into the phone and it will produce text, again, as another way of communicating in real time with our student. Next slide, please. And again, I'm just going through a couple of low tech and high tech. And again, in this particular situation, it won't make too much of a difference for our student, but to note that clear masks have really come a long way. Again, I guess I can say now my third perk of the pandemic is clear masks have really made an appearance, and they have been created in a much stronger way in which we have some options now for N95 clear masks that can be worn in surgical spaces as well. I do want to just acknowledge that there is always complaints about them fogging up, and with my little bit of research I did, I've actually found a few solutions that literally include putting things on the inside of that mask, such as you can even do like just a bit of soap. You can use, I know it may sound gross, but your own saliva. They even say some toothpaste, and that actually helps prevent the masks from fogging. So again, a low-tech solution may not work particularly for our student right now because they don't necessarily use lip reading as their primary method of communication, but to acknowledge that this is an option that exists. FM systems as well can be used in various circumstances. And speaking to this, again, not for our student Jane, but to acknowledge that there are different kinds of microphones that can be used with these FM systems. They directly connect to a student's hearing aids, which essentially amplifies the voices. There are omnidirectional and multi-directional microphones. So an omnidirectional microphone will pick up omnidirectional will pick up from the one person who's utilizing the microphone, and the multi-directional multi-directional microphones are for like something like rounds where you can sit it in the middle of the table and it will pick up various speech. Lastly, there is visual and or amplified stethoscope. So what I've done is also put a picture here of what looks like, what you can see is the visual components of a stethoscope for a student who again has no hearing but is now able to visually see the heart rate, which is, I think, again, some really wonderful technology that is coming out. So again, my excitement, I apologize, but I just left this link here in the web or on this slide as well, which also has some really wonderful resources for other students who are in medical and or healthcare professions in terms of potentially other options for our students who may be deaf or hard of hearing. I'm going to pass it over now to Lake Porter for some other case studies.
Hi there, everyone. I'm Lake, and I'm a male with short salt and pepper hair, wearing glasses, and wearing an open-collared white shirt with a green t-shirt underneath. So let's do case study number 2. In this case, we're talking about a student named Sonia Chan, who is a first-year Masters of Social Work student, and they are doing their practicum in an off-site outpatient clinic specializing in youth and addiction. We are accommodating ADHD, and some of the functional limitations we know about are weak organization of case notes, insufficient information recorded with those case notes, and difficulty formulating conclusions or a plan at the end of the clinical meeting. Next slide, please. So I have a snippet from our initial interview here. And so our first question is, how is practicum going? Answer, I've been getting negative feedback on my case notes, my case histories. Question, what is the experience of doing a clinical interview like for you? Answer, I feel like the information comes too fast and in a disorganized way. At the end of the interview, I can't formulate the disorganized information for my case notes. Question, what is the negative feedback that you've received? Answer, my supervisor is saying that my case notes are disorganized and my treatment plans are poor. Now, some of you may be thinking that my students here are very forthcoming and straight to the point. That's partially for the sake of the case, but it's also somewhat realistic because when we're working with students who are in professional programs, they are often coming to us with a lot of self-efficacy from doing their previous education. And they're also in high stakes placements often. So they are very aware of challenges and problems that are coming up in those placements and gets right to the point. Next slide, please. So then we do the COPM scores with Sonia, and we're doing the issue of organization of case notes. So to start with the performance end, I say, on a scale of 1 to 10, how well would you say you're able to organize your case notes, where 1 is you can't do it at all, and 10 is you couldn't be better at it? Sonia gives herself a performance score of 3. Then to move on to satisfaction, on a scale of 1 to 10, how well are you satisfied with your performance, where 1 is it's not working at all, and 10 is it's working perfectly? Sonia gives herself a satisfaction score of 1. So at the very low end of both of those scales, Sonia's ability to perform with respect to organization of case notes is low by the student's report. Next slide, please. So the first accommodation we're going to try with Sonia is the use of templates to help support and scaffold the clinical interview process. And now some of you might be thinking it's a little bit odd for the adaptive technologist to be talking about templates. And I became the template guy at Accessibility Services because at some point I advocated for templates as being a useful accommodation in many placement situations, and also testified that I use templates myself. So I became popularized as the guy who does template accommodations, quite by accident, I'd say. But the template we're going to use with Sonia is the SOAP template, which is an acronym that stands for Subjective, Objective, Assessment, Plan. And I'm not going to go deep into how to use this template, except to say that this is a template that is extremely commonly used in social work areas. I had an opportunity to touch base with a colleague who is a social worker and has worked in such placements as like hospital emergency rooms. And they report that the SOAP template is a very common social work template. You can find all sorts of medical templates, including SOAP, online for a free download. They're also super simple to make. The other thing that I'm going to point out is that it's a good idea to coach the student that they should be talking to their supervisor about the use of this template and consult with their supervisor about whether it's the best template that they can be using. A lot of organizations have their own templates, and of course, if an organization has their own template, they probably would prefer that the student use that template first and go from there. Next slide, please. So after a couple of weeks, Sonia comes back to us. And my first question to Sonia is, how are the templates working out? And Sonia's answer is, the feedback is getting better, but I'm forgetting details. So now we're going to bring some technology into this accommodation. And that is going to be the LiveScribe Echo Pen. And we're going to keep the idea of using templates. Now, the LiveScribe Echo Pen is a pen. It uses normal ink, but it has a recorder built into the pen. And it also has a little camera that watches what you write. And when you use special paper, we call it the dot paper because it has a very fine matrix of dots over the paper. The sound that's recorded will be matched up with what is written. So after, when the recording is stopped, you can tap where you were writing and hear back what was being played at that particular time. Now, with so many pieces of technology when used as an accommodation, it is very important to think about strategy. And if you think about a normal strategy for taking notes, usually you listen to what the person says and then write down your note. But if you're trying to match up the print on the paper, the marks on the paper with the sound of what is related to that note, then you will want to put a little dot or an asterisk as soon as a new topic is being discussed, so that when you click on that dot or asterisk, you're hearing the actual sound that you want to hear, as opposed to the sound that's coming after what you want to hear. Now, templates can be printed onto this dot paper. The dot paper usually comes in books, but there's always a perforated way for you to tear a page out, and so it can be fed through a printer. Next slide, please. Now, I've actually gone low-tech again, and I have just used a pen to draw out the SOAP template on this dot paper. I have an image of the dot paper here. You can see that the matrix of dots is very, very fine. And I've written out subjective, objective, assessment, and plan spaced out over the paper, so that the student, Sonia, can write in between and then click where she's writing to hear back the what the client was saying while she was making that note. Next slide. Now, I know that those of you whose wheels are turning right now are thinking, but wait, a social worker recording their clinical interviews, what about confidentiality? And that is a very important issue that needs to be addressed. It's necessary to, of course, check with the supervisor that this accommodation is even possible, and plan for measures that must be taken to protect confidentiality in this circumstance. In some cases, recording is possible, but the device is locked in the supervisor's drawer when it's not being used in clinical interviews. And this is how confidentiality is protected. And with that, I'm going to pass it back to Michelle for case number 3.
Thank you, Lake. So our third case is Mr. Bobby Pye, and they are a first-year occupational therapy student, and their first practicum will be in an outpatient rehab setting. So one of the clinics that is outside of the hospital for outpatient folks who are coming in from hip and knee replacements. And some of their primary work and their primary responsibilities will be around education and teaching around how to do ADLs, how to use mobility aids, some of the exercises, just moving around, et cetera, et cetera. So this is Bobby, who has a diagnosis of mild cerebral palsy. And now Bobby does have some functional impacts as related to fine motor challenges. So not the greatest in terms of their fine motor control and coordination. It does take them much longer to complete documentation and any kind of writing or typing sort of functions. There are some mobility challenges. This student does use a cane and or a mobility aid essentially when needed because of fatigue challenges when standing or ambulating for too long. And again, we've completed the COPM with the student, and they have indicated that their biggest concern was around getting their documentation completed in a timely way. So their performance score was a 4 and their satisfaction score was a 3. So again, on the lower end of the COPM. And I just wanted to also acknowledge that the student, of course, is currently in classes and is working on various strategies for their documentation, but was concerned about going into a clinical site and ensuring that they had everything they needed to be successful in this occupational therapy placement. Next slide, please. So just a few considerations. I won't go into too many details. I alluded to these at the beginning, but of course we are concerned about Bobby's abilities for their documentation because that is one area the student has also indicated as their biggest area of concern. We want to ensure that the location is in a site in which the student is able to attain. So we also want to, again, considerations that we would also be a part of this, which is not necessarily on the tech side, but how far they have to get to their placement. Again, acknowledging that sometimes the travel to and from can be just as tiring and add to the fatigue and add to a student's day. So we are cognizant in the students because of the mobility issues, we are considering their site locations and the size of the site. So is it a small clinic? Are they taking up a whole floor? Are they only in a few particular client rooms? How is that going to look? Again, the pace of the site. How many clients, how many patients will they be seeing in a day? What are the hours? What are the expectations? And then, of course, the biggest piece is around patient safety, because again, we recognize that these clients are coming in as post-surgical, having hip and knee replacements. And we, of course, have a student who has their own mobility challenges. So patient safety is going to be another consideration we want to keep at the forefront as well. Next slide, please. And now I apologize, I haven't really alluded to maybe as much of the collaboration we'd be doing here with the programs, but of course, the first piece to this, not only are we pulling all of the student information, but we're speaking back to the programs, making sure that there are no issues with the particular sites. Again, ensuring that the student is able to complete all of their core competencies within that placement site. So again, knowing the site is a really important factor in considerations for all of these technology pieces that we'll now discuss. So essentially, we are knowing that the student will be needing to do some form of documentation. So again, is that handwritten? Is it technology? In this particular situation, we would be looking to see how we can adapt for the student to be able to ensure that they are using a more high-tech option for their note-taking and charting, as we are aware of their fine motor issues. So the student does have quite good success using speech-to-text software, and they've been using that throughout their education. I believe in one of our sessions earlier this week, we talked a little bit about Dragon Naturally Speaking. They have a special sort of medical edition that we would also want to ensure that the student had access to, as it picks up some of the more technical jargon around medical and rehab pieces. So we would want to be ensuring that we could look at this as a speech to text option for the student. So a few other things that we can potentially think about here, and again, this is a bit of an exhaustive list, and we would want to narrow it down a little bit to what the student's preference would be, and of course, what is going to be available at the site. But iPads are also, again, another tool that a student can use for their speech to text. They may be able to actually do some note taking in that moment. The Apple Watch has also come up with some really great new technology that connects to MS OneNote. So the student could also be taking some notes off of their watch and doing a speech to text into their watch, which then transfers into a OneNote that, of course, we would ensure is in a secure area of the site, and making sure that everything is password protected to ensure confidentiality for all of our patients and clients. So we would also, again, when it comes to even the documentation pieces, is thinking about breaks and extra time. I apologize, I didn't write extra time here, but breaks and extra time would also help support, knowing that the student may have to do some additional editing when they are doing speech to text. I'm sure we've all had notes from our doctor's offices at some point that sort of have a little line at the caveat at the bottom that says dictated but not read. In these cases for our students on practicum, we do want to ensure that they are dictated but also edited to ensure clarity for everyone who will be reading them. And then of course breaks, because we do appreciate that this can be a little bit more taxing cognitively as well as physically for this particular student, just due to some of their fine motor challenges as well. It's also important in this particular situation to think about keeping somewhat of a set schedule for the student. So is there a way in which that we can kind of ensure that the student is working through the various segments of the practicum in a way that is also fitting to their own needs? So again, thinking about the mobility challenges and the fatigue, we want to ensure that the student is taking appropriate breaks and on an appropriate schedule. So this is a student who maybe we don't do a 40-hour week. They may have to do potentially a reduced load, and then we may extend the practicums or allow them to do some weekends to make up some of those hours, but we can maybe flex some of their schedule as needed. And then lastly, in terms of the fine motor component here, thinking about other adaptive technologies such as compression gloves if the student is having any issues or concerns or any inflammation in the hands during this time, or other adaptive technologies that help actually what they would call like lessen the grip. So again, we have an OT student in an OT placement. And OTs, and yes, I am also an occupational therapist by trade, so I can say this, but we also have some really great ways of using some of these adaptive technologies and adaptive devices. So when we're teaching our new clients about how to use them, it's kind of great that we can be the experts on how to demonstrate this. So in this case, Bobby would be able to also demonstrate some of the grip tools that they may be using that might assist some of the clients that we are seeing as well in this rehab facility. Next slide, please. We do recognize that this is a site in which there are hip and knee replacements, and therefore, and again, also some older individuals who may need some assistance for lifts and or transfers. So in this particular situation, we would also want to ensure that Bobby is either assisted, so that there was always a 2-person assist or even a 3-person assist, depending on the patient or client that they are seeing, and or utilizing the technology such as a ceiling lift or a Hoyer lift, which also can allow the student to not have to utilize their own body to assist a client and keeping that client safe. Because again, one of our priorities is patient safety as well as student safety. We also are considering the fact that the student may be in a larger setting, so they may have to go to various rooms, various sites, depending upon the clinic size at that hospital. So 2 areas we may want to think about are having the student have a spot to sit and or chairs or stools in various locations for the student to be able to take some time and rest between, or when they're doing various aspects of their work with their clients, they may be able to sit versus standing. And again, if it's a larger site, is it more helpful to have the student use something like a scooter to get from point A to point B to minimize fatigue and restrict and reduce fatigue levels and allow them to actually be able to engage even longer with their clients or their patients? And I alluded to this earlier around the site close to home or transit, because again, we're looking at a student who has a mobility challenge, and we want to ensure that they are able to access the site as well as they would if they had to if they were at a site closer to home. Next slide, I'm going to pass it back over to Lake for case study number 4.
Hi again, everyone. So study number 4 is a third-year medical student named Peter Kahn. Now, by the end of this presentation, you may notice that all of our medical students are in third year, and that is not by accident. In third year medicine, at least here in Ontario, this is when clinical placements start. And so this may be a time when even with disabilities that we don't think of as changing in a student's life, the education changes. And so the way that disability intersects with the education experiences a change. And so ways of accommodating that the student has experienced before may no longer work. And of course, in Peter's case, we are accommodating a learning disability that affects reading, which is one of those disabilities that we don't typically think of as changing, at least not at Peter's age. Functional limitations include a slow reading speed with word transposition problems or poor word recognition. Next slide, please. So again, I have an interview snippet for us to read through. So question 1 is, good morning, Peter. How is your placement going? Answer, placement is going pretty well. I'm in a family medicine clinic and I'm enjoying the pace of the work. However, there is a lot of reading to do and I'm having trouble keeping up. I've always needed to spend extra time on my reading, but I no longer have the extra time to spend. Question, have you ever used technology to help you read before? Answer, I remember having Read and Write Gold recommended to me when I was in elementary school, but I never used it. It was important to me at that time to do things the same way as my peers. So the thing I wanted to bring out in this interview snippet is the fact that early interventions, like in elementary school, often give a good clue as to what might be going on with this education change and the intersection with disability changing. And of course, we see here that Peter was actually identified with this reading problem, and technology was attempted to be put in place back in elementary school, but for whatever reason, Peter didn't use it at that time. And I think we can assume that Peter continued through all of his education without needing technology, just spending extra time on his work until now in placement, and he no longer has the extra time. Next slide, please. So we do the COPM scoring with Peter. On a scale of 1 to 10, what would you say your ability is to complete your readings in a timely manner? Peter gives a performance score of 6. On a scale of 1 to 10, how satisfied are you with your ability to complete your readings in a timely manner? And this time, Peter gives a satisfaction score of 1. And this is a good illustration of how the COPM can identify performance that actually may be on the upper side of 5 in this scale of 1 to 10, but satisfaction is very low because of the demands of the placement or the environment. Next slide, please. So University of Toronto has what's called a web license to some software called Kurzweil 3000. Kurzweil 3000 is a reading technology that is designed to support reading when it is affected by a learning disability. What Kurzweil 3000 does is it enlarges the text while putting a moving highlight behind the word that's being written while reading the text out loud. I'll also point out that I like this image that I've included on the slide of a tablet with some reading glasses. Ironically, the tablet is a Kindle. Kurzweil 3000 does not work on Kindle. It's actually one of the few platforms where we can't use Kurzweil 3000, but I like the image. Kurzweil 3000, our license, can be used on any computer connected to the internet so long as the student has their login credentials. Next slide, please. Now, this does not solve all of Peter's reading problems because there is one computer in the clinic where patient charts are being read, and it is not connected to the internet. It is only connected to the local area network. Now, we need to find a different tool for Peter, and Microsoft Office is on this computer and is used to read the patient charts. Microsoft Office has a feature called Immersive Reader, and Immersive Reader is a feature that shows up in Microsoft Word, Microsoft PowerPoint, Microsoft Outlook, as well as Microsoft OneNote. And I actually just learned yesterday that Immersive Reader is also used in Microsoft Teams. Peter can use this Immersive Reader, which is a feature that's designed to accommodate reading when reading is being affected by a disability. And it reads the text aloud while resizing the text and changing background color, as well as font, changing font and changing spacing. One thing to point out, and this leads us into the next slide, is that you may need to download additional learning tools in order to get Immersive Reader in your particular version of Microsoft Office. And you may have noticed that Microsoft Office very much depends on which version of Microsoft Office you're using, whether you're using it on your desktop or whether you're using it online, and which version of the desktop software it is. So you'll get different features in different places. Next slide, please. So this is where the adaptive technologist may need to communicate with the site IT person. As I mentioned, additional tools may need to be installed to make Microsoft Office work with Immersive Reader. And IT might also need to make exceptions in their firewall to allow Kurzweil 3000 to establish its credentialing process. Next slide. And this brings us to the fifth and final case study. We are working here with Sandy Plonquette, who is, again, a third-year medical student who is in the placement of a neurology ward at a hospital. We are accommodating a nonverbal learning disability, and functional limitations include difficulty thinking on the spot, especially when asked questions during rounds. Next slide, please. So here's our interview snippet. Question: Good afternoon, Sandy. How is placement going? Answer: It's super stressful. I'm getting put on the spot a lot in rounds, not knowing how to answer the doctor's question. I freeze and end up saying nothing. They get frustrated with me and move on before I can get myself together and answer. I also find that I frequently don't know the answer to the question as well. Next slide, please. So now we're going to do the COPM on two issues. First of all, answering questions on the spot in rounds. So on a scale of 1 to 10, what is your ability to answer questions on the spot in rounds? Sandy gives a performance score of 2. On a scale of 1 to 10, how satisfied are you with your ability to answer questions on the spot in rounds? Sandy gives a satisfaction score of 1. And then a second issue, on a scale of 1 to 10, what is your ability to know the answers to questions that are asked in placement? Sandy gives a performance score of 5. And then finally, on a scale of 1 to 10, how satisfied are you with your ability to know the answers to questions asked in placement? And Sandy gives a satisfaction score of 3. Now, I want to point out that when a student has a nonverbal learning disability, you can get a lot of different issues happening. In fact, nonverbal learning disability is not included in the DSM-5 because it is so hard to pin down as to what might be going on. But what usually is the case is that the student has a deficit in spatial reasoning and what we call performance reasoning. And if you think about it, placing something on a scale of 1 to 10 is a very spatial activity. So if you're working with a student with a nonverbal learning disability, you might find they have a lot of hesitancy and work with the COPM scoring in a very slow way. And there's some ways that you can scaffold this. If you purchase the COPM, you will get some laminated scoring cards, which actually have the scale of 1 to 10 listed out. And that can be very helpful to scaffold the student's ability to pick their place on that scale. You could also use the more fulsome language to describe the question, like I did in the second case study with Sonia, the Masters of Social Work student, where I actually defined the scale a little bit by saying 1 is you can't do it at all, and 10 is you're perfect at it. Next slide, please. So many medical students use quick reference tools, especially in placement as they're walking around the hospital. Most of these quick reference tools can be accessed on an iPad, which I have a picture of here. The student is in the best position to determine which references will work best in their particular placement, and they can find that out by asking their supervisor for suggestions, but also their peers in the program will be seeking out these quick reference tools. Now, if we're using an iPad as an accommodation in placement, especially in a hospital, it is very important to consider how the student is going to be carrying this iPad. Will it fit into the pocket of a lab coat? Will it need to fit into the pocket of scrubs? Are those scrubs provided by the hospital, or does the student have their choice of scrubs where they can choose the size of pockets? Will the student have a locker where they can put the iPad when they need to go into rooms at the hospital where the iPad can't follow them, like, for instance, the surgery? The other thing that will be important to do with this strategy, with the student, which I touched on with Sandy's case study, which would be to develop a strategy for using the tool. So for instance, the student might need to be very conscious of looking up relevant information in between patients, perhaps even while walking from one patient room to the other. Also having information at their fingertips while they're being asked questions on rounds. Next slide, please. I also wanted to talk about mind maps. Now, when medical students are learning differential diagnoses, I would say that it's even a best practice to use mind maps to learn these differential diagnoses. Now, I am not a medical educator, so take that best practice with some advisement. But I have noticed over the years of working with medical students that this is a very common strategy students use for learning differential diagnosis. And just to quickly describe a mind map, I have one pictured here. It is far too small to read, so don't try to read it. But you have a main idea at the center, which can be represented by a picture. And then main ideas branch off in a radial way. And then sub-ideas further branch off of that. And the actual differential diagnosis I have a picture of here is the differential diagnosis for headache, which is one of the largest differential diagnoses. So I picked it on purpose just to show you how large and complicated these mind maps get. Now we have a problem. Students as I mentioned, with nonverbal learning disabilities often come with poor spatial reasoning skills. And that's what a mind map taps into first. So a student with a nonverbal learning disability might have the comment that a mind map takes perfectly good information and ruins it. Next slide, please. This is a slightly more manageable differential diagnosis for shoulder pain, also in a radial mind map. But I wanted to show you some ways that a mind map could be adjusted so that it works better with students with nonverbal learning disabilities. Next slide, please. So we can use a left to right mind map. And I have one pictured here. It is far too small to read, so please don't try. But this is only half of the shoulder pain differential diagnosis. So you can imagine that the full differential diagnosis for shoulder pain is going to go on for quite a bit. And this is where the feature of a mind mapping software to collapse the branches will be very useful. And to create this particular mind map, I used a software called MindView, which is the mind mapping software that we use most frequently here at University of Toronto, but there are many options. Next. Thank you. I didn't even get to say slide. That's great. I just wanted to finally show you that you can further adapt learning differential diagnosis just by an ordered bulleted list. But again, this is only half of the differential diagnosis that I have up here on the screen. So you can imagine these lists will be very long and the students will need strategies for actually committing these lists to memory. And that's it for case study number 5. We can go to the next slide and move to some questions.
Thank you so much, Michelle, Anne, and Lake. There are a few questions. I noticed 2 of them were answered. I'm just going to read them out so that folks are aware. One of them was, for tools such as the COPM, can only specific groups administer these? For example, just OTs. Anne's written that no, the COPM is designed for OTs, but many other teams use the tool as an intake tool or interview guide. They often expand and focus on other issues not covered in the COPM, but the interview and scoring methods are transferable. Reliability and validity is based solely on the use of the original COPM though. And then somebody else asked, is there any technology for listening to the lungs? And Michelle wrote that the visual or amplified stethoscope can listen to the lungs as well as the heart. There was a question here about the EchoPen. So it says, while the EchoPen for recording is great for paper-based systems, what do you do for an electronic medical record system like Epic? So I know you mentioned the Dragon, the medical version of Dragon. So curious, does that work with Epic or medical record systems?
This is where it will be important for the AT or the advisor to be in communication with either the placement coordinator or the actual placement site to determine whether the medical record system will work with whatever technology is being used. Now, in Sandy's case, where we're using the EchoPen, the student might actually take their notes in the clinical interview on paper with the EchoPen and then type them up later. And it might be necessary for the student to have an accommodation for some protected time to type out those notes from the paper or dictate them with Dragon. But yeah, I don't think my AT colleagues come with a great knowledge of what the various medical record keeping systems are capable of, and we would rely on the hospital's IT to get that information and continue to problem solve as a team.
Mm-hmm. Great, thank you. A related question. Do you have any speech to text suggestions for students who struggle to speak clearly? I work with several students with cerebral palsy who find it difficult to use Dragon because of speech difficulties. I appreciate that you mentioned that editing is still required, but I'm speaking more about students that have very limited mobility as well as speech issues when they're using technology.
So did you want to?
No, go ahead, Michelle.
I was gonna say there are definitely times when some of this technology just may not work for students, and that's okay. So we recognize that if there are speech impairments, and again, you're right, like there are definitely some students with cerebral palsy who do have some speech issues, and in various ways, speech to text may not be the ideal option. So it may be that we are actually exploring something completely different, and it could be, I would actually probably argue that speech to text in that situation may not be the best option for a student who has a speech issue, as well as with a fine motor challenge. We may actually want to look at some various other technologies. So it could be, again, can the student utilize, can they type? Do they have any abilities to even use a stylus? Is a stylus on an iPad easier for them than actually pen to paper? I think we would want to explore some other particular technology options in that situation. So I think that there would probably be a whole other layer to that assessment. So I think the reality is we just may not be able to use speech to text in every situation. So I don't know if Anne or Lake, you wanted to add anything else to that, but that has been sort of my experience, is looking at other ways of doing documentation, utilizing other means of technology.
So specifically to documentation when mobility impairments are involved, typing might be the best option. If the mobility impairment is severe enough, typing with a key guard might be important. Oh, there was another thing I was thinking of. Oh, in some cases, thumb typing on something like an iPad or a small iPad mini for smaller, and then iPhone for even smaller, sometimes anchoring the hands and using the thumbs. But this would have to work for the specific student. They would have to have the appropriate thumb mobility and have hands that were big enough to accommodate that thumb typing. But it's just another option that could be explored.
Mm-hmm. There was also a comment that said word prediction to cut keystrokes can also help. And another attendee commented or asked, do you have any experience with students using eye gaze software to type?
I can't say here at UofT we have really explored much of the eye gaze systems, but that's not to say, like I know I haven't in other educational settings and more of the elementary side of things. However, I don't think there's been a lot. I mean, collectively, Anne and Lake have 40 years of experience. They may have seen it more than I have. So there you go, Anne, one time. So it's not as common in the post-secondary with respect to that kind of need. But I mean, I would also, again, I'll pass it over to Lake and Anne if there was any other pieces that you wanted to sort of address.
Like Anne, I've seen it a couple of times. But the most recent time would have been about 8 years ago. The student came into their degree already set up with all of their technology and was a very proficient user of it. That would be important for a student starting a university fast-paced education, to be an expert at their system, and also have those eye muscles built up so that they don't fatigue.
Mm-hmm.
I wanted to also just add, yeah, some students do come to post-secondary with a lot of I guess, experience using various technologies, which maybe we haven't utilized as much here. So again, we definitely do rely on the students to be the experts in how that works for them. And thank you for the suggestion around the word prediction potential use, because that is also like a really great strategy that many students can utilize, especially those who may even also have some spelling or learning disabilities around that.
I wonder, as a follow-up question, are there any instances where you might send students for outside assessments to help with determining certain types of assistive technology?
Lake?
My answer is yes, but I was wondering whether Michelle had some more detail around when we would do that.
So yes, we definitely would utilize outside assessments in a way in which we found that, like, if technology was really, really complex and we did feel like, so for instance, maybe in the example of the eye gaze technology, I wouldn't say that at this point we would be the experts. We'd of course be relying on a student, but there are definitely times when we may look to outside sort of either whether they're vendors or other adaptive technologists within the community. We may want to actually support a student in various other needs. So absolutely, there are times when we may have to send a student out for further assessment. And it's really, again, to connect the technology to their specific academic requirements. I do know that we've utilized some different tech supports and various, even visual assessments to support our students in the various technologies they may need. Again, one of the things I would say we probably don't do as often here at post-secondary is sort of do that training on some of the basic technologies. So I'm going a little off the cuff here to say things like JAWS or screen readers. Those are often something a student is quite well versed in before they come to post-secondary. And I think in the instance of something like the eye gaze, they would be very well versed in how to use it already. So we would likely go back to where they originally got that equipment, and we may want to assess it in that capacity. I hope that helps a little bit.
Did you have anything to add, Lake, or?
You can see the wheels turning in my head. I do have a little bit to add, which is when Michelle says basic technology, another word that Michelle could have used is more fundamental technology, because a screen reader is a challenging piece of software to use, which is why it's so important that a student have a really solid foundation in it coming into the university fast-paced educational environment. And I'm saying university in a professional program, that pace even increases. And then in placements are often extremely fast-paced. So having great expertise with the technology the student uses is of great import for those foundational technologies that the student would hopefully have been using since even elementary school. But of course, with a visual disability, you can acquire a visual disability later in life. And for a student who had a newly acquired visual disability, I would actually give the advice to concentrate on learning the technology that you need for education before entering the fast-paced stream of the education.
Mm-hmm. Yeah, and if it's mid program, taking a leave of absence potentially to learn that.
Because we do recognize, sorry to interrupt, we do recognize that learning that new software or that new technology is quite crucial to the educational aspect. So it's really hard to try to do both at the same time, and trying to learn a new technology and a software, as well as also taking in all of this new academic information. So yeah, it can be very challenging on a student.
Mm-hmm. And along the same vein, there's a question that says, what would you recommend for students who are getting comfortable with tech and that timeline, such as maybe not being comfortable enough for exams, like using K3000? What other type of temporary accommodations might they use? So there's that piece of taking a break during the program. That's maybe a larger thing, but any shorter term accommodations.
So I think that a good answer to this question is scaffolding. And this is where the AT really comes in, to work with the student to make a plan for how they're going to integrate this technology into their program. For instance, let's take the example of Peter, who is going to start using Kurzweil 3000 in his medical placement. Peter has been reading without technology for a very long time, and using text-to-speech to assist with reading is a big change to the way a person reads. So a scaffold might look like Peter starts by using Kurzweil 3000 to read his email Email is more conversational with shorter sentences. It's easier to adapt to how you're reading that. And he saves some time reading his email because the text-to-speech can speed him through that. And then he has more time to read case notes or literature. And then after he's becomes more familiar with text-to-speech, reading his email, then he graduates to reading academic text with the text-to-speech system, having already used it in another context. Sorry to add, but scaffolding with speech recognition, like Dragon, that is very frequently important. In fact, I would say that every student who I recommend speech recognition to, I try to scaffold the process, the learning process of learning to speak to write, because that's a big cognitive change.
Mm-hmm. And the program's learning their voices and things too, right? So we have processes around students going into the test center and yeah, making a voice profile to start. There are no more questions right now. We can wait a moment just to see if any others come in. But thank you so much, Michelle, Anne, and Lake, for your thoughtful responses to questions and your great presentation on different assessments and different tools that can be used. I think this is really great, and I love the use of the case studies too. That was really great learning. No other questions? Well, we're right on time for the next session, which I think is starting at 11:45. So thank you so much.
Wonderful. Thank you so much, health team. Natalie, are we okay to go ahead 1 minute early?
Ready to go.
Okay, perfect. And Jessica is here.
He is.
Amazing. Okay. Welcome, everybody. My name is Morgan, and I will be moderating the student panel. I use she and her pronouns, and I am a white cis woman in my mid-20s. I have long, dark brown hair, and I am wearing a black blazer with a beige shirt, and my Zoom background is of the Pride flag. Could I have the next slide, please? Oh, okay, never mind. Quick access check. Access check is a shared responsibility. We understand access to be a shared responsibility between everyone in this space. We will strive to create an accessible space that reduces the need for you to disclose a disability or impairment for the purposes of gaining an accommodation. In doing this together, we strive to welcome disability and the changes it brings into our space. Is there anything about the virtual space that we should address now? Are there any other access needs that might affect your participation in the workshop that we could also address? If so, feel free to let us know in the chat. Throughout the conference, all speakers will describe visual elements as best they can. We welcome participants to turn off their camera, get up and move around, and take as many screen breaks as they need throughout the conference. Please use the Q&A to submit questions for the presenters, or if you experience a technical difficulty and require assistance. You are able to submit questions anonymously. If you prefer to ask your question live, you can do so with the raise hand feature, and you will be asked to unmute yourself. Keyboard users, Option + Y on Mac or Alt + Y on Windows. Mouse users, select participants, choose raise hand at bottom of panel. We respectfully request that you wait until the designated question period at the end of the student panel to ask questions, either using the Q&A or raise hand feature. Note that moderators may not be able to get to all questions. To enable text captioning, click on Live Transcript and select Show Subtitles. Text captioning is auto-enabled on mobile devices. We also have sign language interpreting for the entire conference, which is available on laptop and desktop computers. Please submit a question via the Q&A feature if you are experiencing any technical difficulties. All right, welcome to the session titled Student Snapshot, My Lived Experience Navigating Adaptive Technology and Post-Secondary Education as a Student with a Disability. Joining us today, we have Jessica Chaikoff. Jessica holds an MA in Sociology Research and Practice from American University and is starting a PhD in Social Policy this fall. As an undergrad, she advocated for the inclusion of students with disabilities by co-founding UofT Access, the first club on campus to support disabled students and to educate members of the college community. Her research focuses on chronic illness, disability, and accessibility in higher education. As an individual living with a disability, Jessica is familiar with obstacles that students with disabilities face in requesting and advocating for their rights. This session will be a conversation between Jessica and myself. As mentioned, my name is Morgan. I am the Peer Program and Transition Coordinator on the Student Learning Team at Accessibility Services. I hold a BAH in Psychology and Sociology, a certificate in Horticultural Therapy, and a master's in Education and Social Justice Education. I've navigated elementary school, high school, undergraduate studies, and graduate student studies as a student with an anxiety disorder and mood disorder. I exist in a space where society defines me as disabled. However, many do not view me as disabled enough to identify with the term because of the invisibleness of my disability. Moving on to the panel, I will be posing a series of 4 questions to Jessica, one at a time, to give her the space to reflect and respond. After each response, I will share a little bit about my lived experience where appropriate. So the first question, how has the COVID-19 pandemic impacted your experience in higher education? What was good about it? What was bad about it? And Jessica, before answering this question, if you could please visually describe yourself for the audience, that would be much appreciated.
Absolutely. So I'm Jessica Chaikoff. I am a white woman with medium brown hair. My background's a little blurry, but I'm wearing a black and white striped t-shirt. So thank you, Morgan and Natalie, so much for inviting me to be here today. I greatly appreciate it. So when I got your questions, I kind of took some time to think about it. And the COVID-19 question is kind of a tough one because there was a lot of good things that did come out of it and a lot of bad things. So one of the positives I want to mention is that it brought in a ton of empathy, but also flexibility, in particular, the ability to do Zoom classes. For example, I have just recently finished my MA in Sociology Research and Practice at American University. And so in my MA program, we have a research practicum, which involves my classmates and myself all working with a faculty member on a research project. In this practicum, there's no structure, there's no syllabus, there's a ton of stuff going on. And often one of the things we had to do is share data on our computers, what we're working on to get feedback. And one of the things we used to do was we used to put it on a projector and try to get it from everybody. And that was not exactly easy, but what my classmates and I found through Zoom was that we were able to do it more easily. We were able to screen share, so everyone can see everything more easily, and it made it much easier to access for us and also to be more productive in our practicum. Sorry, I'm just making sure I got everything. And it also made it much easier for some students like myself. So I have a disability. Sorry, I am very tired. I apologize. My disability is Usher syndrome. And so what Usher syndrome causes is hearing loss, night blindness, vision loss, and vestibular issues. So I'm able to communicate right now very well because I hear and speak with cochlear implants. I have an incredibly difficult time navigating in the dark right now due to my vision. And I cannot drive. And so one of the things that's been tough about my program was that all my classes were at night. And so that was really difficult for me. But with being able to be on Zoom, I didn't have to worry about my safety as much. I could stay in my apartment and be able to get to class easily. Not have to worry about navigating certain things, especially in the Washington, D.C. area, which isn't exactly the safest area to be at night. So those are some of the positives that I experienced. But then some of the negatives I experienced was one, it was really difficult for me to hear with everybody wearing a mask. And some people may ask and say, well, what about clear masks? Do you lip read? And the thing is, I do not lip read. I am a full-on audio learner, speaker. Like, I very much so blend in the hearing world. And it was very difficult for me to communicate because everyone's voices were muffled. And so when my practicum decided to meet in person, we will all be masked, socially distanced. And then another issue we faced that's going to contribute to this was I couldn't get in-person carts, so closed captioning. I could only get remotes, and it was not very sufficient. And so in my practicum, picture this. We have about 6 people. We're all wearing masks. We're all sitting 6 feet apart. We all have data on our tiny little laptops. And in this class, we never sat still. We were always moving around, looking at data, trying to shout at each other. And it was very difficult for me to hear. And in addition, the remote cart wouldn't capture everything. It gave me about 65 to 70% capture rate. And it was even tougher because my professor had this really thick accent. And so it felt like half the time I was lost. And I got really, really frustrated. And so when I made the appeal to my university to get in-person cart services, my university kept making me argument, oh, remote cart's more sufficient because it's dirt cheap. And I'm like, no, it's not working. And so to come back from all this, in particular the negatives, is the masking, but also universities trying to do things that they thought were cheaper, like remote cart, even though it wasn't sufficient. And so I had to spend the entire year fighting for my access, and my university didn't really work with me. And when I finally did win my case to get in-person cart, when I was in person, I had it for a certain amount of time because since my university took its sweet old time, there was only 2 cart providers for the entire Washington, D.C. area. And so to come back before I end this question is A, the negatives were the masking and social distancing, but also universities trying to skirt around costs by doing things like remote cart because it was cheaper.
Thank you for sharing your reflection on those questions. I definitely relate to what you said about the good things, the empathy and the flexibility, also being able to use Zoom and use those online resources. The next question I have here, what are some of the adaptive technologies that you use in the classroom or in general that have helped with your access?
So the one adaptive technology I want to capitalize on in particular is the Roger Pen. So it's an FM system. I'm sure people have already heard of it, but for those who are not familiar, let me describe that to you. So the Roger Pen is a special microphone. And so with this microphone, I get a little neck loop that I put around my neck, and then you get 2 mics, a pass-around mic and one for the instructor to wear. And so what I do is I turn my cochlear implant to telecoil. And so what it does is it connects my implant to that neck loop and that microphone. And so I would hand that microphone to the professor and they would speak through it. But it automatically projects their voice directly to my cochlear implant. And so no one else would hear it but me, which was really great because you don't have to hear yourself or disturb anybody. And this technology has been incredible for me. I've been using it, I would say, since elementary or middle school. And it has helped me so much with group work, being able to hear, and to be able to sit where I want. So there are some students who might want to sit in the back. They don't have to worry about sitting up close. Or if you're like me, who likes both front and center, that's okay. But that technology was absolutely incredible. But there are some shortcomings, and I do want to mention the limits of it, because I think that's very important. Is I did try to use it during COVID when we were having the mask mandates. It was still tough to hear because everyone's voices were muffled. So I couldn't exactly capture everything. The Roger pen could not exactly capture everything. And so that in itself was a challenge. So that's kind of what I have about the Roger pen that I've been using for years. And then the other form of technology I do use, I know some people would argue, may say it's non-adaptive, but I'm going to add it in there just in case. In particular, it's in-person CART. So the full acronym for CART is Communication Access Real-Time Translation. And the reason why I want to mention it as adaptive technology, even though it's a person doing all the closed captioning, is that it's not only benefited me as a deaf individual, but benefited everyone else in the classroom. And so, for example, I remember in undergrad, one of my classmates saying, I like to sit behind you because the CART's really helpful because I can understand it. And I'm not just starting to realize how much I'm missing. But also, even in general, the closed captioning has been helpful on Zoom when we have a live person doing it. My professor who has a thick accent always liked it because he could get the transcript afterwards and see what he missed, what we went over in class that day, and what we covered. And so that to me was one of the best pieces of technology. And so what I often say is closed captioning should be universal. While I understand that in-person CART isn't always cheap, but we should be working to better our access to captioning in the classroom, on Zoom, just about everywhere in a way that works for everyone. And then I want to mention the other form of really cool adaptive technology that I used was when we were on Zoom during my 1 year online before I went in person, was I have vision issues, so I can't see as well, but I have the MacBook computer, which is very good at screen mirroring, an Apple TV. And so my mom and I came up with this great idea where we would mirror my computer screen to a TV. So when the professor had a PowerPoint or diagram to show, we could enlarge it so I wouldn't be sitting there staring at my computer. So that's just kind of one of the things I wanted to mention, because that was one of my favorite pieces of technology that I found to be really clever, especially in COVID times.
Wonderful. I really liked what you said about the CART and the connection to universal design and access and creating an environment that is more accessible in higher education. Is my mic a little fuzzy? Okay.
It is, Morgan.
Okay. I wonder if Jessica, maybe am I echoing in yours? Could you try and quickly mute yourself? Okay. Does that sound more clear?
Much better.
Okay, probably a little bit of an echo. I'll start again, Jessica. I really liked what you said about the CART and connecting it to universal design and access, and then creating an environment that is more accessible for everyone. And then that very creative idea of mirroring Zoom to your TV is amazing. I'm so glad that that worked for you. You were able to figure that out. For the third question, if you could share anything with faculty or staff about your experiences as a disabled student in academia, what would it be?
So this is an interesting question. So as I was going over these questions last night and thinking about my responses, this one I thought would be the easiest question to answer, but was actually the toughest one to come up with an answer for. Because one of the things I want to share first and foremost is that as a student with disability, especially in academia, you're already vulnerable as it is. And academia, in many ways, is a cutthroat environment where I'm not going to deny and say there's backstabbing, there's people who are not always supportive. And so often at times, it's very hard to figure out how do I fit in. But also in academia, there's the ivory tower. Where do you belong? How can you advocate for yourself? Or should you blend in and become part of academia? And so one of the things I want to share as I follow up this question last night, because it was an incredibly tough question for me to answer, was that all students with disabilities really just want to learn. And that all they're asking for is mainly access. And more importantly, what's very frustrating for me, and I see this from both ends, for faculty and students, is it often falls in the hands of the faculty member and the student to come up with things. Because from my experiences being at, I would say, 2 different universities with different accessibility service offices, different people, some accessibility service offices aren't always sufficiently built to support faculty. And so it's always a two-way street. And so what I want to capitalize on here is what I want faculty to understand is that we want to learn, we want to be here. And that more importantly, we just want you to work with us in whatever capacity we can allow you to. And the thing is, not every student with disability is willing to reveal themselves, especially when it's one that's not diagnosed officially or is a deeply stigmatized condition like endometriosis, which is what I'm currently studying as a researcher. But if a student tells you something's going on, you give an empathy, you approach in, and you make them feel like a human. But for me, more importantly, from my perspective, what was always important was the faculty who gave me empathy, who were understanding, and who said to me, what do you need to be successful in this course? That's the question every faculty member should be asking. Because the thing is, not every student is able to get their accommodations approved through Accessibility Service Office. And sometimes some of these accommodations might be able to be approved. And so the question faculty should always be asking students is, what do you need to be successful in this course? What do you need? How can I work with you? But also really emphasize to the student, we're not going to judge you. We're not going to judge you if you have a chronic illness. We're not going to judge you if you need to take 1 minute outside classroom. Like, what do you need? Because to me, the faculty that have always reached out to me and gone to lengths are always the ones who answered my emails, are the ones I worked best with. I can actually give a great example before I finish off this question. So when I was starting my master's program, I was absolutely terrified. I was dealing with a really vulnerable time in my life where I was just coming off a really serious case of blatant discrimination on a basis of my disability. And it took out a ton of my confidence. I wasn't willing to reveal myself or who I was in terms of my disability, but I still needed to get my accommodations. So I reached out to all the faculty for my classes and I said, I'm Jessica Shakoff. I'll be taking their class this coming semester. I have a hearing loss, but I hear and speak well, cochlear implants. I have vision issues. And I gave them just sort of very vague email. And one of the faculty was like, my syllabus isn't finished yet. Let's talk later. But then one of them said, I'd love to talk to you. Let's talk next week. And that faculty member ended up becoming one of my mentors, collaborators, friends, and eventually became her TA. But my point is, as a faculty member, you really need to be empathetic to us. And if a student reaches out asking about what's on your syllabus, even if you don't have your syllabus ready, try giving as much information as possible. Because accessibility, in my opinion, and some people may disagree with me on this, is a two-way street. As students with disability, unfortunately, we had to advocate for ourselves, but also faculty had to work with us, if that makes sense.
Thank you, Jessica. I totally relate to your comment about the amount of effort it takes to disclose. And it's always so transformative when a faculty member does something like as simple as expressing empathy and just providing you with all of that context at the front, so you're able to navigate it in a way that works best for you. I would add to that, something that I would like to share is that I'm not trying to use my disability as an excuse. And I think that this extends beyond the academy. When I ask for a request, any type of request, it takes a lot of effort, just like Jessica was saying. I experience a lot of intense emotions when asking, waiting in anticipation, and even after receiving the reply, regardless of if the request was approved, denied. I don't like drawing attention to myself, and I'd rather not even ask for the request in the first place. So the details that are shared before the class and just creating that welcoming environment is very beneficial. The last question I have here, what changes would you like to see implemented in post-secondary regarding accessibility? Essentially, how can we make academia more accessible?
So that's a great question. And this is exactly what I'm doing right now as a researcher. So I am currently working on a research project that focuses on endometriosis, which is a chronic condition that is mostly found among individuals with female reproductive organs. And what we're looking at is how can we improve higher education for those individuals? First, we're hoping to identify the barriers, but also make it more accessible. But now I want to take a step back and break away from my research and talk about it from my personal experience. So I only know about the American system. So I only know about the Americans with Disabilities Act. I don't know as much about Canada, so I can't really relate to that. But one of the things I want to see is more funding for accessibility services offices. I want to see funding in the way that we fund athletics. To give you an example, I have recently saw an article about University of Georgia in, I think, Athens, Georgia, by this brand new facility for their football players. Locker room, fancy pools. I apologize for noise in my background. That is my service dog making noises. But back to what I was saying. And I'm sitting there, I'm like, this is $20 million. Why are we investing this much in athletics when we can't even make a certain building accessible? Or why are we denying a student with disability a certain piece of technology? But also, more importantly, these offices, the one at my smaller institution for undergrad, had one staff member for about 400 students with disabilities. And they were overworked to the point where we went through a constant turnover. And I remember, while my group, which was called We Access, appealing to the university administration saying, we want another person. We're asking for one more person because we're seeing the athletics departments, which has 500 student athletes and 19 staff members, where accessibility services has about 401 staff person. Like, that to me doesn't compute. Because I want to see more funding and more staff in those offices, because that would solve so many problems. And so as student disability, it's really frustrating to see how often colleges focus on athletics or all those things. And then what I also want to see is better support for faculty, in particular from accessibility service offices. So at my undergraduate institution, it was so overworked that they could only focus on the students. So the faculty couldn't always get their questions answered. And so when they had an issue, they couldn't exactly get a meeting. And so I want to see is not only more trainings, I want to see the faculty, sorry, give me 1 second. I want to see faculty be able to reach out and say, I have this issue with student XYZ. How can I help this student? But also, when faculty have recorded lectures, they should be able to get those captioned easily without even having to think about whether or not they have a deaf student in the class. And I remember talking to my former professors said, some of us would be staying up till 4 a.m. just to caption our recorded lectures. And so as a faculty, you're already loaded and overworked, and then you don't have the support. So that's the main thing I really want to see. And then more importantly, my last thing is I want there to be a focus on accessibility services being more individualized. And what I mean by that, it's not black and white. Disability is not a monolith experience. Everyone's disability, their experience, their definition of it is different. And so therefore, we all need to focus on the student. What does the student need? How can we better support the student? Not been a list of approved accommodations. Thank you.
Definitely, I agree with that. More equitable funding for resources, including service providers and resources for those service providers. And then also that individualized support. I would add flexibility, as you mentioned at the beginning, especially as it relates to making space for students as embodied beings and learners who hold a multitude of lived realities, and bringing it back to empathy, also more patience and a focus on active listening. Thank you so much, Jessica. We have 1 minute for questions, folks. So if you want to submit a question in the Q&A or unmute, feel free to do so. We have a few comments in the chat, Jessica, just thanking you for sharing. And good luck in your studies.
Thank you. And I will also, if anyone wants to follow up on this conversation, I'm going to type in my Twitter into the chat. You can find me easily on Twitter, just request to follow me because I'm on private right now for personal reasons, but I'm happy to continue this conversation on Twitter. So let me enter in my Twitter.
Thank you, Jessica. Okay. No other comments, and it is 12:15. So if you're wanting to continue this conversation with Jessica, reach out on Twitter. And I believe it is now lunchtime. So thank you again, Jessica, and we will see you back at 12:45. Enjoy your lunch.
Welcome back, folks. Welcome back to the virtual space. We're going to get started. I hope you had a refreshing lunch break and that you're ready to continue with our remaining sessions for today. My name is Jasmine Montagnese. I use she, her pronouns, and I'm working as the on-location accessibility advisor for Professional Faculty South for the St. George campus. I am a white woman in my late 20s with long brown straight hair, and I'm wearing a patterned black shirt with pink and white flowers and green leaves. My Zoom background is blurred. I'll be moderating the next session entitled Clinical Sites, Academic Programs, and Accessibility Offices, Roles, Responsibilities, and Best Practices in Working Together. I'd like to start the session with an access check. We understand access to be a shared responsibility between everyone in this space. We will strive to create an accessible space that reduces the need for you to disclose a disability or impairment for the purposes of gaining an accommodation. In doing this together, we strive to welcome disability and the changes it brings into our space. Is there anything about the virtual space that we should address now? Are there any other access needs that might affect your participation in the workshop that we could also address? On the next slide, we will go over how you can submit a response to either of these two questions, as well as for the rest of the conference. Throughout the conference, all speakers will describe visual elements as best they can. We welcome participants to turn off their camera, get up and move around, and take as many screen breaks as they need throughout the conference. Next slide, please. This slide shows a visual of the Zoom control at the bottom of your screen. Use the Q&A button to submit questions for the presenters, or if you experience any technical difficulties and require assistance. You are able to submit your questions anonymously. If you prefer to ask your question live, you can use the raise hand feature and you'll be asked to unmute yourself. For keyboard users, click the Option and Y buttons on a Mac, or click the Alt and Y buttons on Windows. For mouse users, select Participants, choose Raise Hand at the bottom of the panel. We respectfully request that you wait until the designated question period to ask questions using either the Q&A or Raise Hand feature. Please note that moderators may not be able to get to all questions. To enable text captioning, click on Live Transcript and select Show Subtitles. Text captioning is auto-enabled on mobile devices. We also have sign language interpreting for the entire conference, which is available on laptop and desktop computers. Please submit a question via the Q&A feature if you are experiencing any technical difficulties. It is now my pleasure to introduce our next two speakers who will be presenting on clinical sites, academic programs, and accessibility offices, roles, responsibilities, and best practices in working together. Dr. Pearl Levy has worked in the field of learning disabilities for over 40 years and holds a PhD degree in special education from the Ontario Institute for Studies in Education in Toronto. She has worked as a disability advisor at Accessibility Services at UofT since 1990. And in 2017, she has been in the role of accommodation specialist for practicums, placements, and laboratories. In addition to her work at UofT, Dr. Levy has had a private practice in Toronto from 1986 until 2017, where she conducted psychoeducational assessments and provided consultations for both children and adults. Dr. Tony Pignatello is the Associate Dean in the Office of Learner Affairs, Temerty Faculty of Medicine. He is a child and adolescent psychiatrist, associate professor with the Department of Psychiatry, University of Toronto, and the medical director of the Provincial Pediatric Telemental Health Services at the Hospital for Sick Children. He has worked in many academic and community-based settings and has won awards for his teaching, mentorship, and work in virtual mental health care. Please join me in a warm welcome to Dr. Pearl Levy and Dr. Tony Pignatello.
Great, thanks very much, Jasmine. If you could get us to the first slide and in the process, just for further introduction. So I'm going to start, we're going to do a little bit of a tag team. I'm going to start at the beginning. So also in terms of describing myself, I'm a white male, medium built, early 60s with short white hair and glasses. I'm also have a blurred background. And just as a heads up, I have two guests with me in the room, and they're two standard poodles, and I can't guarantee that they won't try to contribute to the conversation today. And you may see some vague movement behind me, but we'll manage the best we can going from there. Pearl, did you want to talk about yourself next, and then we can go to the next slide?
Sure. I am a Caucasian woman in late 60s. I have brown curly hair that is pinned up, and I'm wearing a black shirt. My background is blurred.
Great, thanks. So maybe if we could go on to the next slide. So what we're going to try to do this afternoon, we're going to set the context of the work within accessibility services within the Human Rights Code and regulations. We're going to talk about roles, responsibilities, and processes in navigating accommodations, and a little bit of time on barriers and how to overcome them, looking at future trends, and we'll be using a couple of case scenarios to demonstrate some of the points and for the discussion. Next slide. So some of the questions that we hope to address, and this is based on past experiences in talking about this topic. So often people want to know about the processes, what happens when a learner wants to apply or get approved for accommodations, if these are negotiable, how they're monitored over time, how requests should be vetted, and what are the implications in terms of extending training for those who have lost clinical time. For example, limited shifts, no overnight call. Does it compromise their clinical learning experiences? A little bit on the legal aspects of this, and sometimes there seem to be what we call extreme requests, and how do we manage those in a supportive and EDI perspective. Next slide. So why do learners register with accessibility services? What prompts them are oftentimes with more encouragement. By far the greatest reasons have to do with mental health related issues. And then there's a variety of other, if we will, physical medical issues, so acquired brain injuries, learning disabilities, visual challenges, hearing challenges, ADHD, not infrequent, and some with mobility and functional challenges, and also some learners on the autism spectrum realm would have specific needs and specific challenges. But again, emphasize that by far the greatest request has to do with mental health concerns. Next slide. This is a quick snapshot over the last couple of years, looking at data from accessibility services and the number of health profession students who register with accessibility services. As we'll describe for you in a few minutes, we have a very close working relationship with what we call UofT Central Accessibility Services, and I'm with the Temerity Faculty of Medicine supporting undergrad and postgrad learners. This refers to undergrad learners, so it's medical students, other health professions students, occupational therapy, medical radiation sciences, physician assist, MD, PhD students. So even just looking over the last couple of years, there seems to be a slight trend upwards in terms of numbers of students who are registered with accessibility services. So in 2019, It was 115, the next year to 128, to the most recent at 141. Not enough to say that there's a significant trend from our end, but definitely trending up. In my understanding that this is pretty consistent with what's happening across the board with accessibility services at the university, where there've been significant uptake over the last few years. Next slide, and over to Pearl.
So I'm going to talk a little bit about how human rights legislation structures the work that we do, and what are the different roles and responsibilities in providing accommodation. Next slide. One of the things that we keep front and foremost is that students with disabilities have to meet the same program standards with accommodations. Next. The framework provides that there's no accommodation given without an individual request. Medical documentation has to establish the need for accommodation, and the whole process needs to be individualized, dignified, and respectful. And the information that we receive is confidential and only shared on a need-to-know basis. Next. So what is the role of accessibility services? As Tony mentioned, our offices work very closely together, with each having fairly defined roles and then a lot of interaction. So the first thing we have to do is to verify the presence of a disability on behalf of the university. We have to provide relevant information of the impact on the learning and performance only on a need-to-know basis. And we have to facilitate accommodations for learners. We need to support faculty and staff to assess and meet their legal obligations. And very important throughout the whole thing is to ensure that due process happens. Next. Tony.
Thanks. So in terms of the role of our office, we are the Learner Affairs Office. We use the term learner because technically what we call as postgraduate medical trainees are not students. They're learners, but we work with undergrad and postgrad students, learners like I mentioned. And our office is there to support learners as they navigate their way through systems and processes and policies on the way to optimizing their performance to be the best that they can be, and then advocate with them in situations where advocacy is important. So what our role is, we're kind of like the liaison point of contact often between the learners and accessibility services. We do collaborate extremely closely with accessibility services. We meet, talk on a very regular basis, have quick access to each other on an as needed basis, on a per case basis. But we really want to emphasize how critical it is that this relationship is there. That's how really things get resolved and we move through things quickly. We also at our end serve as the liaison between the learners and the program. We will help both the learners and the program navigate through how to implement the recommendations that come from the assessment recommendations from accessibility services. So we're a key liaison and an information point. I should also put on there that we do a fair bit of faculty development as well with our faculty who are not necessarily as aware of the issues related to accommodations, and we help facilitate that as well. Next slide. So what do the learners need to do? Well, they need to provide adequate documentation as required. They need to collaborate in deciding on accommodations, they need to follow procedures, and as Pearl alluded to, they need to self-identify to the university and initiate communication. So it has to come from them, although we play a role in making them aware of how this works and supporting them and walking them through the process. Next slide. What do the programs need to do? The programs need to be clear on what the learner must demonstrate regarding knowledge and skills to meet the essential requirements of the program. And sometimes we've had to work with programs to be very, very specific. You know, if a learner has can't use their hands, for example, and they're on a surgical rotation, we've had to get very specific in terms of what are the elements within that surgical rotation that the learner must demonstrate, and how can we work around that. And then we've also had to get as specific information as possible from the medical team supporting the learner so we can liaise with the program in terms of how to implement. Early communication is very, very important, and collaboration. Look at the accommodations and make sure that they're reasonable and can be applied within the particular clinical setting. We're all actually responsible for ensuring due process, and really it's at the program level that the accommodations need to be implemented. And so again, we have to work very closely with the programs to be clear on what implementing those accommodations looks like. Next slide. In terms of faculty or staff working with students, this is not just for accommodations, but I think it's any situation where it's we're providing support to learners. As educators need to remember that they're there as educators, not as medical providers. Sometimes this can be a little bit challenging for medical educators. Sometimes they can be a little bit gray in terms of when do you slip into medical support and so on, but it's very, very important to be able to make that distinction, to be careful not to diagnose students. We may have our idea or impressions, but we're not there to diagnose. And faculty members are there, need to respond appropriately to a disclosure, and obviously respecting the student's privacy along the way, and be careful not to share information as a minimum without the student's awareness and consent. Next slide. So it leads into maintaining confidentiality. So accommodations must be discussed with the learner in a private setting. Be careful not to reveal learner's name or specific accommodations to the class or its small groups learning sessions, and including a statement in the syllabus about disability and willingness to accommodate. It is part of our standard goals and mission statement, but it's important to be clear on that as well. Next slide. And I think this is over to Pearl again.
Okay, implementing accommodations. It's important not to provide informal accommodations, only specifically recommended ones. That becomes really important when one has to demonstrate a history of receiving formal accommodations for licensing exams. Often faculty are tempted to just help out and coming from the best place, but ultimately it's not a good idea because you can't track it and you can't speak to that when writing letters for licensing exams. It's really important that everybody works to ensure testing accommodations are in place on time, have to communicate with TAs or coordinators to ensure accommodations are properly implemented, and educating TAs and coordinators on confidentiality is really important. Next. So going back to the human rights framework, one of the things that we talk about is essential requirements, and that's so important to hold front and center as we talk about accommodations. So essential requirements is a specific term used in human rights legislation, referring to the bona fide requirements of a task or program that cannot be altered without compromising the fundamental nature of the task or program. Determining what is an essential requirement and what is not is critical in distinguishing requirements that cannot be accommodated from what can and should be altered. Next one. According to the Human Rights Commission, essential can be defined by two factors. It must be demonstrated to meet the objectives of the course, and the skill must be demonstrated in a prescribed manner. Essential requirements and competency must be determined in good faith and not as a way to exclude someone. So these are often hard questions that one really has to sort of grapple with. Is there really only one way to achieve the same goal? And the bottom line is that the person has to meet the essential requirements with or without accommodations. Next one. According to the Human Rights Commission, the duty to accommodate requires that the most appropriate accommodation be determined and then undertaken short of undue hardship to meet the essential requirements of a course. And a person will only be considered incapable of meeting the essential requirements if the needs of the person cannot be accommodated without undue hardship. Next. So it's important to consider what has to be considered to determine undue hardship. In the policy and guidelines and disability and the duty to accommodate document, 3 factors have to be taken into account. Firstly, what is the cost of the accommodation? And that is based on the operating budget of the institution, not accessibility services or department. So that's a hard one, as those of you who heard Sari Springer talking the other day, that would be a hard one to argue. One has to explore outside sources of funding, and it must got to be explored before claiming undue hardship. And health and safety. Does a student pose a health and safety risk to himself, herself, or others that would amount to an undue hardship? This is a high threshold. Therefore, accommodation must be fully explored to the point of undue hardship. Next. What are the minimum standards for accommodations? Accommodations may not jeopardize the safety and well-being of others or the academic and professional integrity of the program. The university or the program must demonstrate that health and safety standard is reasonably necessary and that accommodation cannot be accomplished without incurring undue hardship. Next. So learners in professional programs may experience difficulty with the academic or clinical components of their programs. Accommodations that are appropriate for a classroom setting might be unreasonable in a clinical setting. Accommodations in practical settings require balancing the needs of learners with disabilities while ensuring that professional standards and responsibility are not compromised. And practicum settings are the most challenging ones to accommodate. Next slide. So there are unique demands of the clinical settings that make it us sometimes only aware of learners for the first time. So for some learners, the unique demands of the clinical practicum environment reveals disability-related issues that were unexpected and that did not require accommodations in the past. So we'll often encounter learners who did really, really well, in fact, excelled in the academic part of the program, that were good at tests and exams, and that you put them into a clinical environment and suddenly problems emerge that one sometimes anticipate and other times are completely surprised by. What are some of the reasons? The volume of new information, the variety of complex settings, the adaptation to different supervisors, different expectations. This is often challenging for learners to go between different styles and different settings. Disclosure of disability, that becomes a huge factor for many people. It's a question of, like, do they disclose? When do they disclose? Who do they disclose to? And where does that information go? And these are often real challenges that learners often bring to the accessibility advisor to navigate and to discuss and to work through. And I'm sure Tony's office hears that too. There's a lot more unwritten rules, lack of routine and predictability in one's day, which particularly for some learners is very challenging. We heard from Kevin started this morning about students on the spectrum, and for students that fit into that category, would be a real challenge for them. Absences for disability-related reasons impact on colleagues and patients and students. So it's not just like missing a lecture. They can get their notes, they can make up somehow, but when they're working within a team, it's a much harder thing to navigate. Next. So there are a lot of barriers that learners have to confront in the practicum setting and in the general program. One is stigma, fear of repercussions from having accommodations. That's a very real concern for many learners. And in some cases, they will opt not to get accommodations, particularly in practicum settings where they might be more visible because of the fear of repercussions and what it might mean for them, for their profession going forward. There's often poor communication between different parties. We've spoken about the interactive process and very different players involved and so many pieces that have to fit together, and that can be challenging for everybody. Is there a culture readiness for accommodations? How are these requests for accommodations received? And trying to obtain appropriate and relevant documentation, particularly when there's long waiting lists to get to see treating physicians. Next. So the interactive process has got to be done in good faith. And it involves collaboration between learners, accessibility services, OLA, and the different programs. And in order to get to this point, we've got to consider what are the functional limitations resulting from the disability, what previous accommodations has the learner received. Often we need to do a task analysis to really figure out what would be the most appropriate accommodation, what are the anticipated barriers, and very importantly, we must document the decision process. Sari Springer referred to that on Wednesday. For everybody's protection, it's really important that the arrangements are not done on the fly, but that they're done carefully and documented so that everybody has a recourse. Next slide. Some of the accommodations that we put in place now are fairly standard and can go, virtually automatically, but there are others that require a lot more sort of teasing out and questioning. There's a need to ask 4 questions as outlined by Meeks and Jane. And these are questions we ask of each other, we ask of ourselves, we have to go back and forth to really figure it out to come to the right answer. Would the proposed accommodation result in a failure to meet any essential requirements of the program? Would the accommodation legitimately jeopardize the safety of others? And the word legitimately is very important, that we really consider that fully. Would the accommodation fundamentally alter the education program? These questions are best answered through collaboration between accessibility services, advisors, program faculty, field placement instructors, and the learner. And of course, at Tony's office. And we often have that. We often have those conversations, as Tony alluded to earlier on, where we get together quickly, perhaps with the learner, whoever's involved, to figure out, okay, does this work? What is it? How's it impacting? Can the accommodations help? And are the essential competencies still going to be met? Next slide. Another important way of looking and deciding on accommodations is to do a task analysis. Before you have to really know fully what's required before you can figure out creatively often what kind of accommodation could work. So the first thing is, what is the purpose of the course? Is the competency integral to the learning of the course? Does the skill need to be performed in a prescribed manner? Would accommodations require fundamental alteration to the nature of the program? What are the outcome variables that are absolutely necessary? Why? What methods of assessing outcome variables are absolutely necessary? Why? Is there only one way for the skills, knowledge to be demonstrated? And would there be any significant consequences if the skill were performed at varying levels of competency? And again, this is something that, talking it through with the various parties, you can really sort of figure out and push the envelope a little bit sometimes, and not take the idea of accommodations lightly, but make it an informed decision. Okay, next slide, and over to you, Tony.
So we're going to talk a little bit about strategies for accommodations in clinical settings. And so some points to consider, some places to start, for example, a reduction of caseload or graduated increase of responsibility and caseload. Other opportunities to do readings in advance, reading client cases ahead of time, consulting with peers or supervisors and reviewing clinical notes, and that would then also enable more time to carry out a task. It may be necessary to take time away from clinical work so the learner can get treatment, to work on strategies, obtain adaptive technology, and get trained on it. So as an example of what we do in the medical program, students can definitely take a leave of absence and be away from the program for a period of time to get some things up to speed. We define a leave of absence as a student being away from the program for sufficient enough time that they can't complete the requirements of the program within that academic year. And so a leave of absence would come into play. We also have flexibility in scheduling. So for example, in the clinical clerkship year, not infrequently, we will do things like stretching out the 1 year over 2 years, and therefore allowing, for example, a rotation on, rotation off, and slowing down the curriculum, if you will, to adapt to some of those situations where students may need more time or more prep time. There could be opportunities to shadow or observe clinicians in the setting prior to formal entry. Similarly, we've had situations where we have connected learners with peer mentors to help them not so much with the learning, but adapting to the culture and the expectations of the learner within that particular setting, in that particular environment. We can and have provided templates for taking case histories and clinical notes, and these can also be implemented during test taking, for example, and in clinical-based exams, and modifications to the attendance policy. And we've done things like advocated for students to have more time to prepare for tests, or allow them to be excused from certain things. Certainly, it's not an accommodation, but there are opportunities for students to have absences for religious events as well. But sometimes we've had to go the route of accommodations when it's been even a request that's outside something that the program as a whole can accommodate or can include. Next slide. Pearl talked about adaptive technologies, I believe, and there's a variety, and again, it involves working with the learner on what's available and what they would find useful. Of course, there's costs that have to come into play, and this again is where we will have discussions with accessibility services with our programs. We don't pass these on to the learner, but we do have to look at cost considerations and how to get those covered. Talked a little bit about protected time to review files and write up case notes. Record feedback and supervision sessions for later review, very, very important. That feedback is provided in a written way as well, in a way that the learner can access, and also for due process crispness. Coaching around time management and organization is something else that can be provided for students who have challenges in these areas. Clinical coaching for social skills and professional settings. So a couple of things. We do have tutoring, if you will, clinical skills building tutoring that we offer within our program, and provide that to students. And I gave the example earlier in terms of social skills in the professional setting. We've seen this, for example, probably more so with students who are on the spectrum and have a very difficult time reading the environment and responding adequately and appropriately. And simulation can also be used to enhance learning opportunities or make adjustments to the learning situation that can be more flexible, and also in a way that's comfortable for students. Next slide. Okay, so we've got 2 or 3 case scenarios that we just want to use to highlight some of the things that we've talked about and have an opportunity for a little bit of discussion, the best way that we can. Maybe I will. There's a question up there. I can address this right now. How does funding work when students need to complete degree over longer time? So we stretch out the tuition. So there's flexibility and adjustments to the way that tuition is managed, and that allows them to work with that. That's right. Jasmine, was there something that you wanted me to say or do?
Nope, not at all. Just keeping track of the questions.
Okay, great, thanks. Okay, so here's our first case scenario. I should also say that these brief vignettes are based on actual situations that we have encountered. There's very little information to try to preserve the identity and privacy of the learner involved, and please do not take this information outside of this session. So this case is a trans learner was requesting a switch to a more trans-friendly clinical site. So this learner was in a particular site, had concerns about the site and actually the community that they were not experiencing as trans-friendly. And they had come to us requesting a switch in sites. And this was a novel situation for us. And it didn't technically fit what we initially thought with our criteria for a transfer. And so this allowed us the opportunity to work with Pearl and the team and looking at this from a human rights perspective, and then how should we think about this and how we should approach it. So maybe we can just take a couple comments through the Q&A feature in terms of people's thoughts on how they might approach this from an accessibility perspective.
So it's Natalie here. We do have a raised hand from Lavinia. If Lavinia can be unmuted to ask her question, that would be great. Oh, sorry, Lavinia's hand has gone down. So now can Laura Bulk be unmuted so that Laura can ask her question?
Hi there. Are you able to hear me?
Yep, we can hear you.
Okay, great. Thank you. This is really helpful. I'll let you know the chat function is not turned on, so folks won't be able to make their comments there. But I was going to say, one of the things that comes to mind for me with this scenario, first is that it might not fit within my role as an accessibility advisor because our focus is working with disabled folks. But it might, in terms of if they are registered with us, we don't want to send them to different places to get their needs met. Another piece that I can imagine coming up in the conversation is the need to be able to navigate those kinds of environments in practice. So similarly, if a student struggles to work with people who have a particular diagnosis or presentation, the conversation often comes up that, well, in any setting, someone with that presentation might show up. So I can imagine that coming up in the conversation, and then also thinking about, and they're a learner right now. So maybe it's part of the scaffolding conversation. Yeah, it's a challenging one, as much as I'd like to say, well, we'll just take them out of there. That seems like an awful place to be. Yeah, I'll stop there so someone else can jump in.
Thanks. Is there any other comment, Jasmine? Maybe we'll take one more if there is one, otherwise I'll just give a summary of what we did.
I don't see any other hand or comment right now.
Okay. Excellent. So we actually did a multi-pronged approach with this. Obviously, this is not a disability, but it was an issue that actually prompted some important discussions that needed to happen. So obviously, we looked at it from a learner individual perspective. We wanted to make sure that the learner was in an environment that they felt safe, physically and psychologically safe in. And part of the other support for moving the learner to a different location is because the community they wanted to go to was closer to the individual support that the learner was receiving. So it was also an issue of proximity to the specialist services that they were receiving. And this opened the door for the conversations at a systems level to look at what does this mean. And it raised things like, if there were concerns that the learner was not feeling safe in the assigned clinical site, then we also needed to look at the clinical site to see what was going on there and make some changes and do some staff and faculty development around that as well. And then we also had to manage the optics of this, because the site that the learner was going to go from had concerns that they would be viewed as a negative site going forward, and so managing messaging in terms of a switch or move over. But in the end, it was a positive outcome. The learner has now graduated, and hopefully we assisted in that process. Okay, next slide. So this is probably, I don't know if it would be familiar to you, but certainly something that we we saw a little bit of an increase in. So a learner with medical or mental health conditions is requesting no overnight calls as those were impacting their sleep and medication schedules and have the potential for negative impact on their physical and or mental health condition. We'll take one or two thoughts, comments, questions on this. As you continue to contemplate, as you can imagine from a program perspective, the concern of the no overnight calls and how would that manage, what impact would that have on the rest of the team members. And I'm going to say there was another element that we had not anticipated, and this is unfortunately another thing that we see too frequently, and that's learner-to-learner mistreatment. And this is where the importance of privacy and maintaining dignity and respect come into play. So we had a scenario where a learner then was actually being lack of a better term, teased by colleagues that they weren't really doing the call experience, that they were doing a lesser version of it, and then that caused further distress to this one particular learner. So I think we should always be aware of that. We need to keep checking in and talking and discussing, and sometimes there would be unforeseen or unintended consequences of the accommodations in their application. Pearl, did you want to comment on how we would, we've approached these kinds of situations?
Sure, and I see there's some follow-up questions as well around that, or comments. So I guess generally when we get this kind of request, which is not that infrequent, perhaps to increase a little bit, we really try and understand the functional implications. It's not a sort of a I'd rather not, or it's not a preference. We try and get medical documentation that really talks to that specifically. So it's because it has implications at lots of levels. It's one of those things that we will request more documentation. We will ask the treating professional to weigh in very specifically. Sometimes it might be a 10 p.m. stop time or 11 p.m. stop time. Sometimes it might be a makeup time on weekends. But generally speaking, we go back and forward. There are some learners who say they think it might be a problem, but they want to try it. They want to get that experience. Or they start with it and they say, see how it goes. And often it does go okay. But I think when we've had those situations, we often get together and we sort of talk about the documentation we have, how specific it is, how strong it is, hearing from the learner their own, lived experience with that and how it implicates. And we've been able to be successful in getting that as an accommodation from time to time for sure. Want to add anything, Tony?
Yeah, I'll address the two questions that are up. So wouldn't call be considered an essential requirement? Not necessarily, actually, and some programs do not have it as an essential requirement. What do people get at a call? One of the biggest things is the opportunity continuing to manage a particular situation, but more importantly, after hours, or working within the system when it's not full staffing, it's skeletal staff, and all the resources are not available, managing a situation, when it's unexpected and unforeseen. And so we look at what is the essential requirement that comes out of a call experience. And we've been able to, as Pearl alluded to, make adjustments to the learner schedule so that they do stay on until 10 or 11 in the evening, for example, so that they capture some of the after hours kind of experience, or do the extra time over the weekends and maybe do 12-hour shifts over the weekends. And how do we manage this from medical school to residency or fellowship settings, especially in small situations where call is an important part? Again, a lot of discussion. I don't think it's starting to trickle over towards residency and fellowships. It's not quite there just yet. And I think as time goes on, we'll get more and more experience with this. But it's similar to the response which is provided to the other. And certainly, when there's a small cohort, the learners themselves who are requesting this accommodation often also feel like they're letting the team down or guilty or guilty about that. And so those also have to be addressed. And then I should also say as well that there are some rotations where if you remove the call element, then the learners don't spend the required time in the rotation. And so for some learners, then they've had to extend the rotation. They've had to come back and do 1 or 2 more weeks on a rotation so that they get the required time in there. It's interesting that fellow learners are abusive, isn't it though? Yeah, isn't it though? And we about 20% of the mistreatment that learners report in surveys and so on, about 20% of those are attributed to learner mistreatment, and that's student to student, resident to student, resident to resident. And it's a concern. It's a real concern, very difficult to get a handle on. And we look at ways to address this at individual and systemic levels. And oftentimes we may not have recourse, but we turn to things like the code of conduct and looking at those. What repercussions did those learners face? Again, it really depends on the person who was the recipient of the mistreatment and how they would want to proceed. And if they come to us, then we would proceed with their approval and awareness of what the options are. And sometimes we have then also gone to the other learners to relay the information to them. And if it's felt to cross that threshold of misconduct, then we would go with that route. I hope that answers those questions there. Maybe we can move on to the next case. Certainly lots of discussion came out of this one. So this is our third case, and I want to talk about a slightly different perspective. And what about when is it really an accommodation, or it's actually evasion of meeting a requirement and downright actually manipulation of the system? It certainly doesn't happen often, but we've certainly had situations where it has happened. Situations where a learner may actually be misusing or using the concept of retroactive accommodations to avoid being held accountable for something. So what this means at retroactive is that, for example, if a student took an exam, didn't pass, and then afterwards it was discovered that they should have had accommodations implemented for that exam, and they weren't implemented because the student wasn't identified as needing accommodations, or they chose not to use them, then the student has the right, if you will, to redo the exam with accommodations in place. And then if they pass with accommodations, then the previous failure gets rescinded. So there are situations where it's become a little bit iffy, and it's a bit of a, if you will, manipulation of the concept of retroactive accommodations. And then there's certainly been situations where students will has tended to use accommodations quite excessively, but then actually not use them. So an example here is accepting the accommodation of having lectures and so on transcribed, which this generates volumes and volumes of written material that the learner actually never used, but it was also a way of trying to move from or deflect from or evade the requirement of the course. And then we've also had issues where the learner will consent to agree to having accommodations relaxed, but then when they're not successful with the test, and they come back and say, I never agreed to that, or actually I wasn't, it was my anxiety, I was not capable of consenting to having those accommodations relaxed when I said to go ahead with that. And even with careful documentation, this has been an argument that's been used as well. There's plenty more to this, but we thought this was an interesting scenario to raise to you, to see if you've had anything like this and any thoughts on how to manage this.
We have a question in the chat. So if that's okay, I can read it out now.
Yes, please.
So the question is, I am interested if you know how many learners who have not sought these types of accommodations, despite being recommended by their physicians, as they were reluctant to based on stigma and fear or negative evaluations.
I can start, and then Pearl, please feel free to jump in. Honestly, we have no way of knowing. I mean, it is an issue. It is a problem. We know there are students who do not seek accommodations in the first place. There are students who we pave the way to the warm handover to accessibility services. They don't follow up. We convince them to get accommodation recommendations in place, but then they choose not to use them for a number of reasons. And in general, learners, and definitely medical learners, are quite worried about the longer term repercussions. So medical students, for example, are very worried about not matching in the residency programs. And so they don't want to do anything that they fear will jeopardize that match. Residents and fellows, their big fear is of not getting a job if it's found out that they had these in place. And I suspect that, I mean, you saw that the graph that I showed that there was a slight trend upwards of students with accommodations. I imagine that's just the tip of the iceberg. And we talk about the barriers. I'd say that's one of the biggest barriers is getting students to be aware of, take advantage of the process and have the accommodations applied. I should just a couple of things along that. We've had situations where we've tried to take a stepwise approach to the recommendations. For example, take 1.5 times the time for a test. If that doesn't work, go up to 1 3/4 time. We found that actually is very difficult to implement because it could be a long process where they try that doesn't work, then we have to go back and retroactive accommodations, and it just goes on and on. So the approach that we take is, let's just state what the accommodation recommendations are, the maximum ones, and put those in place, and then leave it up to the learner to require those. But we do see it on a regular basis, and even students who accept that they have accommodation recommendations may use them once, but then they want to try it on them the next time, and it's very, very difficult for them to accept that they need the extra help and support. So again, I imagine the numbers are far larger than what we're seeing. Pearl, do you have any better sense of that?
Yeah, I think just to reiterate, like what Tony said, that sometimes it's a process to getting the student to agree or to recognize that accommodations could be helpful. Oftentimes they're reluctant to come to accessibility services, and it takes quite a few prods, sometimes a failing midterm evaluation that might push a student forward. And generally speaking, I think once they come, hopefully, I think one important role of the accessibility advisor is to really talk it through and to understand the implications and worst case scenarios, and what would happen if they didn't get accommodations, how would that look in terms of career advancement, in terms of ultimate performance. So it is a lot of back and forward, but sometimes it does take a while to get buy-in, and sometimes they might want one accommodation but not another. Especially in the clinical environment where it's more visible when they're needing something. And again, asking for letters of reference, they want to put up their best face forward, and it becomes tricky, the whole idea of who knows what. But yeah, as Tony said, we have no way of quantifying how many people that would be, and there may be many who are not using accommodations at all and prefer to just get the grades that they get, but not have accommodations, which is unfortunate, but it's their prerogative, to choose how they want to do it.
Yeah, and a couple of strategies that we used, to help mitigate that is, we tried to reassure our students that they don't have to report accommodations in any, in their CARMS application. They don't have to disclose those at any point. And we have a little bit of, we don't have a lot, but emerging information that using accommodations actually there's no correlation with not matching in a CARMS situation. And the other piece of information that we make students aware of is if they're likely to need accommodations in future, that's best going to be informed by accommodations they've had currently or in the past. So for example, when it comes to writing the MCC exams and the request for accommodations, the LMCC will ask for documentation of earlier accommodations applied, and that will pave the way. And that's sometimes been helpful in encouraging the students to utilize their accommodations. Okay, I think we'll move on to finish off the last few slides and then open it up for questions from there. So what are we thinking in terms of future trends? Well, obviously virtual learning that was all kind of hit with a vengeance over the last 2.5 years. A lot of talk about it, but now it is there, and that brings up a whole new realm of accommodations that could be required. This was alluded to earlier, the downstream effects due to increase in volume of learners requesting accommodations, that question about what happens in residency and fellowship and into staff positions with someone who needs accommodations. As we're starting to see that trickle at the undergrad level, we don't have a lot of information just yet as to what that's going to trickle over to going forward. And a culture shift. Two things with this. It is, it's a culture shift. That's all there is to it, from the learner perspective, from the program, from the faculty perspective. And we certainly see that some programs are more ready than others to embrace this and to try to work with it. We're seeing fewer programs saying, well, no, they have to be able to do this. They can't do this without, if they need accommodations, they can't do this specialty or this rotation. So we're seeing, it's anecdotal at this point, but we seem to be seeing that shift very, very slowly diminishing. And as we're clear with the programs that that they have a requirement to, it's an obligation to accommodate, and they try to say, what about this, what about that, and we try to be very, very clear that no, it comes back to it's something that has to be done. And the collaborative nature of the relationship, when we've said it a few times, but we really can't underscore this enough. It's not just about if you do this, then that. There's a lot of nuances to each case specifically and individually, and the only way you resolve those is with collaboration and ongoing active discussion and communication. Next slide. And the rest is just for information. There are some references listed here for you. And the next slide, how to contact us. And I believe that's the last slide, yep, in our formal presentation. And these slides can all be made available to you. We, however, would remove the case scenarios just for privacy of the people who may have been involved.
Thank you, Dr. Pignatello and Dr. Levy, for your presentation. We have about 2 minutes to answer a few questions. So I see one that's in the Q&A box, and it says, when too tired to access assessment services and accommodation applications because of a previous bad experience, what are your suggestions?
I guess I'll take that one. I think the important point, the important thing is to get the person through the door at accessibility services or Tony's office, and have that conversation and have an honest, open conversation about what went wrong. And there are many situations where the process of getting accommodations, whether it was in elementary school or high school, undergrad, that have not been optimal by any means. And many students come into the university feeling that our office smacks of special ed, and that was not a good experience for them. So just getting the student to come through the door and be able to have a conversation and be heard, and let us have a discussion about what will be different this time, and really try and live by that and make it be a different experience. But I think that is often the hesitation, and I think that's our job, just to let them come at least, and often say, like, no obligation to register, come for a discussion, and let's see where we go from there. Tony, do you want to add to that?
I would say exactly the same, and it is just that have a discussion, and we'll talk with students. We'll try to get an understanding of what the negative experience was before. Try to say that this, every situation is different. Look at what could be done differently to be helpful, and then sometimes it's just providing information to the student in terms of what the process is, how it works, what's likely to happen, and then leaving them to think about that further, and then checking in again with them, and because sometimes we do have to do more active outreach to continue to keep the student engaged and moving in the process. I would also say we also informally keep our eye on how the student is doing, and if they run into difficulty again, then we can reach out, intervene, and say, okay, are you ready to look at this now, and let's try this again now, and hopefully it'll be a different experience.
Thank you so much. That actually brings us to the end of our time. So I wanted to thank Dr. Pearl Levy and Dr. Tony Pignatello again for this rich discussion about clinical sites, academic programs, and accessibility offices. So I believe now I'll be handing it over to Natalie Roach for the next session. Thank you so much.
Hi, everyone. It's Natalie Roach here, one of the assistant directors for accessibility services at the St. George campus. I am a multiracial woman. I have my hair in a very high ballerina type bun. It is black. I'm wearing an orange top and gold earrings, and I have a background that features artwork celebrating Pride and Indigenous History Month as well. It is my pleasure to be introducing Heather Kelly for our next session. Dr. Heather Kelly is the Executive Director, Student Life Programs and Services in the Division of Student Life at University of Toronto, St. George campus, and is responsible for a comprehensive program of programs, services, and resources for students, which include academic success, accessibility, career exploration and education, Center for Community Partnerships, housing, Indigenous Student Services, Multi-Faith Center, student engagement, student success, and T-card services. She is committed to supporting all students, particularly underrepresented and equity-deserving students, in finding their purpose through the integration of curricular and co-curricular experiences that encourage their meaningful goals and interests. She also holds a doctorate in education from the Ontario Institute for Studies in Education at the University of Toronto, with a research interest in the impact of academic capitalism upon the professional lives of university administrators. It's my pleasure to introduce Dr. Heather Kelly.
Good afternoon, and thank you very much, Natalie. As Natalie shared, my name is Heather Kelly, and I'm the Executive Director of Student Life Programs and Services. I use she, her as my pronouns. I am a settler on Treaty 13 territory, the Toronto Purchase Treaty. I am a middle-aged white woman with straight gray blonde hair in a bob with bangs. I am wearing a saffron print sundress with a necklace of red berries and leaves. My background is a brown wall with two bright red paintings. I would like to begin my closing remarks this afternoon with a hearty thank you to the team at Accessibility Services who organized this conference, our speakers, our panelists, our university and community partners, our students with disabilities who brought their lived experiences, and also all of you, our participants who brought their active engagement and deep listening. I think we can all agree that this was an exceptional learning opportunity. Every year when Mike Nicholson, the Director of Accessibility Services, comes forward with the draft agenda, I ask, are you sure you have the time and resources to do this? In the context of our pandemic response and the tremendous work we've all done to support our students with disabilities as they navigated the many challenges and inequities of the pandemic, this was ever more so a question. And this year being no exception, Mike says, we have to do this. This work matters. And this work matters to all of us. And I'd like to acknowledge the collective work that was done by accessibility services professionals locally and globally in navigating the pandemic, recognizing the flexibility, adaptability, communication, creativity, and innovation that were utilized to navigate this. Overnight, quite literally, you had to use your creativity and deep knowledge of learning and disability to come up with whole new procedures, accommodation, and best practices for virtual learning to keep our students with disabilities in their learning activities. I know in Ontario, for example, the Inter-University Disability Issues Association met extensively and shared best practices and resources among and across institutions, and that this represented an unprecedented time of coming together and sharing to get through a crisis. These same skill sets will be critical moving forward. There are a lot of unknowns about what the world will look like post-COVID, but one thing is certain, we will not return to how we once knew it. We don't really know what in-person means for the future, but that doesn't have to be a bad thing. Initial challenges fueled the rapid development of meaningful changes in UDL, Universal Design for Learning, and we must take from the experience not only what we haven't done, but also what we can do better for students with disabilities. There will be challenges ahead this fall with a group of students who will need to be transitioned back to in-person learning without having necessarily learned the skill sets around time management, organization, and navigating disability-related barriers to in-person learning that they would typically have coming from high school. Student expectations have changed. The options available for accommodation in classrooms, labs, assessment have greatly expanded. Instructors are bringing new technology and synchronous, asynchronous learning into their teaching. These circumstances will require us to continue to use our creativity and deep knowledge base as accessibility professionals to navigate new, unanticipated barriers, as well as opportunities for accessibility and inclusion. We have learned about the need to dialogue, think outside the box, and find creative solutions. And these skills and approaches were also very much evident at this year's conference. Over the past 2.5 days, we had the benefit of opening the conference in a good way, courtesy of traditional knowledge keeper, Vern Ross. He set us up for some deep learning that took place, starting with the keynote from Dr. Okenlami. He was a strong and powerful voice in setting the tone for the conference. He highlighted the difference between equality and equity and spoke about the ableism that exists even within the disabled community. He encouraged us to think about how to really engage with the idea of true access and how it is the responsibility of the entire institution to participate. We also heard the experience of navigating professional programs as BIPOC students with disabilities. A warm thank you to Olivia, Lauren, and Fatima for sharing so thoughtfully and openly about their experiences with stereotype threat and imposter syndrome and the interwoven oppressions they face in their daily lives. We also heard how to navigate the various kinds of interventions and accommodations that are available when considering students with disabilities and professional programs. Thank you to Irene and Jamie, their insight that we need to expect disability to be in the room and respect the capacities in the room was an important insight, as was the reminder to plan ahead. The legal quagmire of what can happen when accommodations are not provided in professional programs, courtesy of human rights lawyer Sari Springer, was also very helpful. As Sari shared, however, you are among the most sophisticated professionals she knows, and that you are the gold standard. And remember, of course, to document. The intersection of disability, a demanding professional program, and career and art with cardiologist Dr. Blake Charlton helped us to understand about the need to reimagine oneself and not buy into negative and limiting perceptions of oneself. He spoke about how many people with dyslexia have narrative intelligence, but cautioned us against focusing on dyslexia as being a gift. Rather, he said we should focus on the many strengths that people with dyslexia have, but also remain cognizant of the many challenges they face. We also heard how technology and innovation can bridge the accessibility gap. A thank you to Jason at Microsoft for joining us. We also had a special video address from the Minister of Employment, Workforce Development and Disability Inclusion, the Honorable Carla Quattro, and we also had insight into her own lived experiences navigating disability. We also heard how the basic principles of UDL look in reality with the Faculty of Information at UofT. I personally appreciated the insight that we need to reject the myth of the average student and empower students to make individual choices about what works for them. There is no one size fits all. It is only one size fits one. We also heard how to support inclusivity in clinical education by using a practicum demands measure with the Department of Occupational Therapy at UofT. To me, this work is an excellent example of the key questions we need to ask together when determining appropriate accommodations to manage student program and practicum site expectations. We also learned more about how we can meet the needs of students with autism. A thank you to Dr. Kevin Stardot, who's shared with us how we need to make more employment, medical, and clinical services available to our students with autism, and how we need to understand autism outside of a childhood context. We also heard the many ways that adaptive technology can be used in professional placement settings. Thank you to Anne, Blake, and Michelle for their case studies, practical tips, templates, and resources. And a very warm thank you to Jessica for sharing a real-life example of the student experience. It was a very important reminder to all of us of the need to ensure continued flexibility for students. And she shared that we need to remember that all students with disabilities want is just to learn. And she encouraged us to always ask this UDL question: what do you need to be successful? And just prior, we learned how clinical sites, academic programs, and accessibility offices can work best together in facilitating practicum accommodations. And a thank you to Dr. Pearl Levy and Dr. Tony Pignatello for reminding us of the need for collaboration and constant communication. I am still excited for what's to come with a special session next from Dr. Michael Kwan and Dr. Camille Monroe from the Ottawa Hospital. They will be speaking about the work they have done to foster inclusion for physicians with disabilities. And Vern Ross will be returning this afternoon to provide a reflection and closing for this conference. So again, I'd like to thank you all for attending this year's conference. The ripple effect from your interest, engagement, and learning in these sessions have sparked new thoughts, new ideas, and innovative approaches that will only increase inclusion for students with disabilities. Supporting equitable participation in all academic endeavors and professional programs brings us closer to realizing inclusive and stronger professions. As one of our speakers shared, notions of professionalism often exclude how disabled people move through this world. As one of our speakers shared, I am capable and I need accommodations. In closing, I already look forward to what the 5th year of this conference will bring, and I hope to all see you there. I will end by wishing you all a very good, sunny weekend. Thank you.
Hi, everyone. Thank you so much, Heather. Those were excellent summary, reflection, and closing remarks. But we're not quite closed yet, but we are going to take a little refresher. So we are going to have a break from now until 2:15. So we will see you all back here in just a few moments. Bye for now. Hi, everyone. Welcome back. I hope you enjoyed your break. I did. I'm actually just trying to make sure I have no roasted chickpeas in my teeth. But I hope you're able to take a little break, and we are going to go into our next session. So I'll start with an access check. For those who haven't heard my introduction, my name is Natalie Roach, Assistant Director for Accessibility Services at the St. George campus. I am wearing an orange top. I have black hair that is pulled up into a ballerina type bun, and I am a multiracial woman in my late 30s. And my background features artwork by Patrick Hunter that celebrates Pride as well as Indigenous History Month. I am going to just read out what we have on the screen here. We understand access to be a shared responsibility between everyone in this space. We will strive to create an accessible space that reduces the need for you to disclose a disability or impairment for the purposes of gaining an accommodation. In doing this together, we strive to welcome disability and the changes it brings into our space. Is there anything about the virtual space that we should address now? Are there any other access needs that might affect your participation in the workshop that we could also address? On the next slide, we will go over how to submit a question or response to either of these two questions. On your screen, oh, my apologies. Throughout the conference, all speakers will describe visual elements as best they can. We welcome participants to turn off their camera, get up and move around, and take as many screen breaks as they need throughout the conference. This slide shows a visual of the Zoom control at the bottom of your screen. Use the Q&A to submit questions for the presenters, or if you experience any technical difficulties and require assistance. You are able to submit questions anonymously. If you prefer to ask your question live, you can use the raise hand feature and you will be asked to unmute yourself. Keyboard users, Option+Y on a Mac or Alt+Y on Windows. Mouse users, select Participants, choose Raise Hand at the bottom of the panel. We respectfully request that you wait until the designated question period to ask questions using either the Q&A or raise hand feature. Note that I, as moderator, may not be able to get to all questions. To enable text captioning, click on the live transcript and select Show Subtitle. Text captioning is auto-enabled on mobile devices. Lastly, we also have sign language interpreting for the entire conference, which is available on laptop and desktop computers. Please submit a question via the Q&A feature if you are experiencing any technical difficulties. It is now my pleasure to move us into our last session of the day. Fostering Inclusion for Physicians with Disabilities. I am going to introduce our two speakers, Dr. Michael Kwan and Dr. Camille Monroe. Dr. Michael Kwan is a general internal medicine specialist at the Ottawa Hospital and lecturer at the University of Ottawa. He is a determined advocate to improve inclusion of physicians with disabilities after his own experience following a terrible road cycling crash and traumatic brain injury. As part of his efforts, he is a member of an Equity, Diversity, and Inclusion Working Group at the Ottawa Hospital and the board of the Canadian Association for Physicians with Disabilities. He will soon be joining EDI advisory groups at the Royal College of Physicians and Surgeons of Canada and the Canadian Medical Association. Dr. Camille Monroe is an assistant professor and clinician teacher with the Division of Palliative Medicine at the University of Ottawa. Dr. Monroe received her medical degree from Dalhousie in 1991, did a rotating internship at Royal Columbian Hospital, University of British Columbia, and then moved to Ottawa. After practicing part-time in family medicine for 16 years while raising her children, Dr. Monroe's interest in palliative care led her to return to an academic setting. Dr. Monroe's current interest is to pursue excellence in patient care and improve the clinical delivery of palliative care. Please join me in welcoming Dr. Kwan and Dr. Monroe.
Thank you, Natalie. So I'm going to get started. And then Dr. Monroe will finish off our talk. So first off, I just wanted to acknowledge that we in Ottawa are working on the traditional unceded territory of the Algonquin Anishinaabe people. And actually, sorry, on that note, I should mention that I go by the pronouns he and him. I'm in my late 30s. I have dark brown hair, dark rimmed glasses, and I'm wearing I'm a mixed Asian and Caucasian ethnicity, and I am wearing a checkered shirt with a dark blue blazer. And so I'll move on to the next slide, please. So just to highlight that we have no actual or potential conflict of interest in relation to this presentation or work. So thank you for the introduction, Natalie. It was really a great opportunity and privilege for us to be here to present the last talk of this important conference with you all. The outline of this talk will be to start with my own lived experience of disability. I'll share some personal health information in my story that I think is relevant to understand the challenges that I faced with disability. We'll then go through my work reintegration challenges and how we can see them now in a different way as opportunities for improvement in this space. Dr. Monroe will continue the talk by reviewing the definition of disability. I know this has been probably talked about already, but just to review for you all, as well as the prevalence of disability data, both in the United States and Canada, among physicians and medical students. Next, she'll go over some background information on physicians with disabilities. Finally, she'll review in more detail our position statement and process at the Ottawa Hospital and the significant impact that it's had, as well as the policy that it has led to. So we're quite proud of this work and looking forward to sharing it with you all today. Next slide. So Natalie gave a nice introduction. I appreciate that. I just wanted to highlight that sort of come at this work with two hats. One, I am a general internist at the Ottawa Hospital and work alongside residents and medical students in inpatient and outpatient settings. But more importantly for this talk, I'm an experienced patient, a traumatic brain injury survivor, and dedicated disability support and inclusion advocate. I'll refer to traumatic brain injury frequently as TBI. So please forgive me for the abbreviations. Next slide. So this is a picture, I'm sharing a picture right now of three young men holding road bikes above their head with an alpine, nice alpine vista in the background. I'm the one on the right. This was my life pre-injury, so I was a pretty avid road cyclist in addition to my medical training. And in 2015, I went on a trip to Colorado to celebrate the end of my residency with a couple of friends. It was a beautiful trip. We were riding some really great climbs and descents and into the Rocky Mountain National Park. And we got a lot of these beautiful views. It was a great trip other than the final day. And next slide. I was just going to close the slideshow for a second, if you can. I'm just going to share with you that what happened. So that morning, I remember it very well. We were sitting together eating breakfast and in a cafe in this town in Colorado. It was memorable for me because we planned our trip back to Denver. We were supposed to fly back from Denver the next day. It was the last memory I had. I don't remember anything more from that day or the next few weeks, and it felt really like I woke up 3 weeks later. I was an inpatient at a brain injury rehab program in Ottawa, thousands of kilometers away from Denver. So having no medical knowledge of TBI from my own medical training, I was learning it all over again, and this time as a brain injury patient with significant disability. And so the first thing I learned was that prolonged states of what's called anterograde amnesia follow severe TBIs, which basically means no new memory formation after the injury, but preserved long-term memories from before. And so this was basically what I experienced for 3 weeks. And so I started making new memories again 3 weeks later, and it really felt like waking up with no memories from the last 3 weeks of my life. And it was it was an incredibly surreal experience, traumatic experience, obviously, but I was then sort of piecing it all together. And what I learned was that I had a terrible and unwitnessed cycling crash on a descent at a high velocity. So it's still, everybody asks, it's still a mystery how or why I crashed. And so a couple of my friends were ahead of me down the slope, and so they didn't see it either. They did kind of climb up the hill again and saw I was getting picked up by EMS, and I was taken emergently to the trauma center in Denver, intubated, stabilized neurologically, and then once things were stable, I was air ambulanced back to Canada. Next slide. So the next slide has a picture of the hospital in Denver where I was admitted for several days, and then and medevac back to Canada. I don't have any recollection of these experiences. Next slide. So the injury itself, after the post-traumatic amnesia resolved, I had so many challenges. First off, I was adjusting to a new life with disability and a lot of new symptoms and cognitive limitations. So there were so many, but I'll try to summarize some of the more pertinent ones. I had significant cognitive fatigue from previously very simple tasks. So I would suffer intense exhaustion if simply walking around the streets of my neighborhood in Montreal where we lived at the time. And it was, busy neighborhood, but exhausting just walking around the streets. I couldn't enter stores. I couldn't enter restaurants because of sensory overload. And so I often was left fatigued profoundly and needed to return home and take long naps. I also had difficulties with working memory and maintaining attention and concentration. So I needed to use frequent note-taking to remember events and conversations. I needed to reread paragraphs and ask for repeating conversations, not infrequently. And I could not, for the life of me, stay focused and attend to multi-person sort of busy, rapid conversations. And then all of this, I put emotional and psychological because there was a real, obviously, strain from that perspective. You know, emotions of grief, loss, disappointment, concerns about my future. They were all a huge burden on my overall well-being. Next slide. Thankfully, I was entering into the rehabilitation phase. I thought the best way to describe it at the time was a feeling of walking uphill. For the first year was the hardest, but and beyond after that year. And the reason I mention that is because it was all a constant challenge throughout every day. You know, sometimes was a bit harder, sometimes was a bit more difficult, but it was always hard. And thankfully, I continued rehabbing and continued recovering with the help of a lot of therapists and rehab, exercise, and support of my supportive wife and neuroplasticity, of course. And so it was thankfully there's so much recovery to be made. It was just a gradual process. And then to give you an example, at the beginning, I was starting with basic reading of simple books, and then sort of reviewing with the SLP. I was practicing, you know, tasks like cooking tacos at the rehab facility and taking buses. Thankfully, I improved so much, and about a year later, I was sort of simulating clinical work activities and doing a lot of symptom management strategies. Next slide. So I tell you all the personal health story. I think it's important to better understand the challenges and barriers that I faced when I was reintegrating to work. So over the next few slides, I'm going to describe some of the challenges that I faced, and then highlight how we can see them as opportunities for improving accessibility in medicine. And I also thought it was important to highlight that every disability and every TBI, for that matter, are different. But a lot of these challenges that I faced are not uncommon among other physicians with disabilities. The existing literature reports that a lot of these barriers are frequently reported. And I put a citation there to an Association of American Medical Colleges special report on lived experiences. They really highlighted a lot of the same opportunities for improvement that I'm going to share with you today. Next slide. So the beginning of my work reintegration was obviously I was happy to be back. But it was daunting at the same time. My internal medicine team. So I was in Montreal. I was working at a community hospital. They were very pleased that I was back. But at the beginning, we weren't really sure how much I could handle. And it was quite obvious when I started that I could not handle much intensity of the work at all. So the first day on the ward, I remember it was very memorable because I basically saw one patient and was totally exhausted and overwhelmed and symptomatic. And it was quite obvious I couldn't do that type of work right away. And so I was slotted into some clinical roles with lower workload, and I started in the outpatient setting. Now, my division in Montreal was very stretched and overworked. And so, you know, I'll pay credit to the situation they were in. They were expecting me to start a full-time practice at their hospital, and including clinic and patient work, emergency consult work, and on-call work. But I started out as a physician with disability who was very limited. So unfortunately, this led to a lot of challenges in terms of navigating the accommodations system in that hospital. So at every step along the way, it felt like it was needed for me to advocate for myself, and it required a lot of energy and time. For example, once I was doing a bit better in the clinic, team felt I was ready to try inpatient work again, and it became my responsibility to sort of go to my colleagues and ask if I could work alongside them on the ward. And some of them were open to it and wanted to help. Some seemed less interested, and it really was a compromising situation for me. I had to essentially felt like I was asking for favors recurrently, and unfortunately, there was nobody really helping me through that process. Next slide. So I put some quotes in here just to highlight the stigma and lack of proper accommodations that I was facing. And they might not be word for word, but they're pretty accurate. One was, we were having trouble with scheduling. We need you to be on the 24-hour on-call schedule moving forward. 2, I remember also being tired at the beginning of my career. It's hard starting out your career in medicine. And 3, is it possible that you're anxious? It might be best to just go for it and take the plunge. These were, after what I had been through, I mean, it was a bit shocking that I was being treated this way, but they were being faced with difficult staffing issues and thought I was working well and thought I could do more than I was actually doing at the time. Next slide. So actually, this was actually, after we moved to Ottawa, I was at another hospital, and this hospital, I was accommodated by not being placed on the ER on-call schedule to avoid busy environments and rapid multitasking and sort of more of an uncontrolled environment. And it was all obviously for reasons related to disability. Thankfully, I continued to feel better over the next couple of years, and I wanted to, and I felt ready and able to try doing some of the emergency room work. However, my physiatrist recommended starting with some daytime work, just to be better rested and control your hours a bit more easily. And I was told that I don't think we can offer you daytime ER work. I don't want to set a precedent. Now, this was told to me in a friendly way, but it was quite bothersome. Felt like I was making a preference choice, and rather than having a recommendation based on disability. So I think it just highlights again the same issues around true accommodations for disability. Next slide. So all of these things, I think, really highlight the need to improve accessibility for all clinicians, and in particular, my disability was a silent or non-visible disability, but it still is disability. We should avoid stigma comments sort of similar to the ones I was facing. Optimally, there would be someone with knowledge of disability rights law, and accommodations in a clinical setting to help facilitate the process. Now, the last presentation, there's more of that, I think, at the postgraduate level and undergraduate level, and unfortunately, in the practice of medicine, there's not. I haven't had any offers for assistance from this standpoint at any of the hospitals I've looked at. Next. So thankfully, as my symptoms improved and my work capacity improved, I wanted to seek out different work opportunities. It was quite clear that the hospital situation in Montreal wasn't working out. So there was multiple issues with seeking out employment with a disability. I wanted to highlight that as I looked for work, I was mainly looking in Ottawa and Toronto, and I really appreciated some hospitals had welcoming statements towards inclusion of physicians with disabilities. And actually, I've since heard from others with disabilities how important these statements are in sort of creating a positive and inclusive culture. Understanding the approach to disclosure and how to ask and request for work with accommodations when you don't have a physician. I'll touch a bit on those after, actually. So next slide. So to improve accessibility in medicine, I think that those cultural statements and ensuring an inclusive and welcoming tone are extremely important. Optimally, there would be some accessibility information provided to physicians, new physicians in onboarding activities, so they're aware of how it's an accessible space. Next slide. So speaking back to challenges, I was mentioning the disclosure and looking for work with accommodations. These were very difficult questions, and I was looking really for guidance at this time. I reached out to the physician health programs in, I think, both Quebec and Ontario, because we were sort of between provinces. And to my disappointment, neither of these programs really had any advisors, and they told me this directly, specialized in physical or cognitive disabilities. Now, what I learned is that these physician health programs were primarily focused on mental health challenges and addictions, which can be seen as disabilities in their own right, but less experience with other disabilities, as I mentioned. My concern was this is limiting their potential scope to help all physicians with health problems. And then same with the disclosure and how to request work with accommodations. If it wasn't going to be the physician health programs, I wanted to try to connect to other physicians who had been there before me. And I was almost desperate to talk to other physicians who had recovered from traumatic brain injury. Unfortunately, these were the sort of quotes I was hearing at the time. We don't really have those resources. We don't offer those services for physicians with disabilities. Next slide, please. Thankfully, and this was through Google searching of my own, I came to the CAPD, which is the Canadian Association for Physicians with Disabilities. And this was not, nobody knew about this or told me about this, and I found it on my own. Thankfully I did, and connected with them immediately. It's a national organization of residents, students, as well as practicing physicians, as well as physicians out of practice due to disability. The main mission is providing network and support for physicians with disabilities, and some of their mission statements include opening avenues for exchange of ideas and information, particularly as they apply to clinical practice, as well as fostering common bonds and lending support to one another. I thankfully connected to them, and they were able to introduce me to, I think there were 2 physicians that they introduced me to who had recovered quite well from brain injury, and it was a really important peer support kind of communications that I engaged with them. And I've since joined the CAPD as a board member. Next slide. So how can we improve accessibility? I think we need to raise awareness for these networks of physicians with disabilities. We need to improve, or we should improve, physician health program expertise with this. And we should try to improve organized peer support opportunities for physicians with disabilities. Next slide. Lastly, I just wanted to mention that because things were so difficult in my Montreal work environment, I had to approach the CMPA to really understand my rights, as a physician, and legally I wanted to understand, what the obligations of the hospital were, what my rights were as a physician. Unfortunately, the CMPA said, "Oh, sorry, we don't have that type of organized information, but we can connect you with a lawyer. And it would have been nice to have some organized documentation for that, but it was very helpful to chat with the lawyer they introduced me to in Montreal. After hearing my story, he explained that most physicians are not protected by the employer-employee relationship at their hospitals, which was concerning. However, I then thought to myself, oh, I wonder what sort of policies might be in place for physicians specifically. And so this comes to my work in Ottawa with Dr. Monroe. And so we did a very informal environmental scan looking to see if there were any hospitals out there with either position statements or policy. And I communicated directly with the largest hospitals in each province and could not find any hospital that had a statement specifically for physicians with disabilities or a policy designed for physicians with disabilities. And so that leads directly into our work. Pass it over to you. No.
Next slide, please.
Excuse me. Yeah. So that's the final piece. Is yeah. Again, improving accessibility. I've alluded to this, but we should really be providing education to physicians with disabilities on their rights, and then we should be creating inclusive policies and practices for physicians with disabilities. Pass it over.
Hey, good afternoon, everybody. Thank you, Michael. I'm Dr. Camille Monroe. I'm a palliative medicine physician at the Ottawa Hospital and Director of Equity, Diversity, Inclusion for the Department of Medicine at the University of Ottawa. I am of East Indian descent, born in Nova Scotia. I have long black hair and am wearing a purple dress with flowers. I go by she, her, and I want to say that it is a privilege to be here to give this presentation, so thank you. I do believe the definition of disability has already been reviewed, but I would like to review it again. So a disability is any impairment, including a physical, mental, intellectual, cognitive, learning, communication, or sensory impairment, or a functional limitation, whether permanent, temporary, or episodic in nature, or evident or not, that an interaction with a barrier hinders a person's full and equal participation in society. It is important to note, as Michael has already said, that the definition includes disabilities of different severity, visible as well as non-visible disabilities, and disabilities with effects that come and go. Next slide, please. So the next slide is a pictorial portrayal of a Canadian survey on disability that was done in 2017 of Canadians aged 15 years and over who had at least one disability, and it is separated by sex. And so the percent of women with at least one disability in Canada was 24%, and for men, 20%. By age group, it's broken down to youth age 15 to 24, 13%. 20% of working age adults aged 25 to 64 have at least one disability. And seniors aged 65 years and over, 38%. And I included this representation and this data because there are many who make assumptions that disabilities affect mostly the elderly. And my presentation is going to be discussing quite a bit of disabilities with physicians. And I wanted to highlight that adults aged 25 to 64 have at least one disability. Next slide, please. So Studies show that medical students begin training with similar or better mental health and age-matched controls. And in 2018, the Canadian Medical Association released survey results that found 1 in 3 physicians experience signs of depression. We generally start out healthy, but something changes as we go through the process of training and then during practice. In 2018, 300 physicians in Ontario were on disability, and of those, the majority were for mental illness. Statistics show that physicians commit suicide at a higher rate than the national average. Male physicians die from suicide at a rate nearly twice that for other men, and for female physicians, the risk is 2 to 3-fold. Yet despite the widespread recognition of burnout and mental illness among physicians, a stigma still remains. And now I'm even more concerned about mental health impact of working through COVID-19. Next slide, please. Research published in 2016 in JAMA assessed the prevalence of disabilities among medical students and the accommodations in use at medical schools in the US. The 91 schools that responded, so about 68%, identified about 2.7% of students identified as having a disability. Of those, 97.7% received accommodations. And what they found was the most common disabilities were attention deficit hyperactivity disorder, learning disabilities, and psychological disabilities. In 2021, JAMA then published the prevalence of physicians with disabilities, and they found that 3.1%, 178 of 6,000 of physicians identified as having a disability, but the percent receiving accommodations was not reported. And in their findings, the most common disabilities were chronic health conditions at 30.1%, mobility 28.4%, and psychological 14.2%. While comprehensive data are difficult to come by, Statistics Canada in 2012 reported 9,000 working Canadian physicians with disabilities. That would be 11.2% of the total compared to 13.7% of Canadians overall who self-identified as having a disability at that time. We did a survey in the Department of Medicine to assess the number of physicians who had disabilities at the Ottawa Hospital as part of the Department of Medicine. We had what we thought was 100% response rate, and it showed that the representations of physicians who self-identified with a disability did not match that of the City of Ottawa for which we serve. So 93.7% said no, 1.7% said yes, and 4.7% preferred not to answer. And so given this data, we questioned if physicians were not self-identifying as having a disability for fear of stigma or biases for promotion and college requirement. And are these physicians really different than the population we serve if we look at the entire array of disabilities? Next slide, please. Research shows that physicians with disabilities are more likely to provide care for underserved and disability concordant populations, and they may reduce disparate population health outcomes and inform healthcare practices for patients with disabilities. Many people think disabilities are the barriers, and perhaps the most dramatic learning can come when it is a peer who has a disability rather than a patient. Working alongside a colleague or a learner who has lived experiences of disability can increase empathy for patients, enrich the learning environment, and can improve the working conditions of colleagues, learners, and patients, and can challenge negative assumptions directly. Next slide, please. Given that physicians with disabilities, as Michael had mentioned, are not employees of their workplace, they require unique consideration and protection at the institutional level. Michael had talked about the environmental scan that we did, and we found that no other hospital in Canada had a position statement or accommodation policies to support physicians with disabilities. And accommodations in the workplace can include flexible work arrangements or scheduling, attendant services, adaptive technology, changes to work site, media conversion, and or interpreters appropriate to the nature of any sensory disability. So at the Ottawa Hospital, a position statement was chosen at the first step. And the idea was to have sensitization of the leadership to the concepts and issues and to help them understand. And what we wanted was endorsement at the senior leadership level, which thankfully was achieved within a couple of months. And we felt that if we worked at the process this way, that rejection of such a position paper would be unlikely. Next slide, please. At the Ottawa Hospital, the Medical Advisory Committee position statement for physicians with disabilities promotes the inclusion of physicians with disabilities, fosters the value of disability as part of diversity within its organization, endeavors to identify and eliminate the barriers to accessibility, is committed to giving physicians with disabilities an equitable opportunity to realize their first potential. They recognize the importance of educating leaders and members on reasonable accommodations for physicians with disabilities. And finally, the Medical Advisory Committee recommended that all departments create inclusive policies and practices for physicians with disabilities. So I am pleased to say that we have had hopefully an impact with the process and statement, in that the Canadian Journal of Physician Leadership published our work that we did to endorse this position statement. Every provincial medical association has published it on their online newsletter. The Ontario Medical Association also did an online news story. The College of Physicians and Surgeons of Ontario did an e-dialogue magazine article. And the national organization Healthcare Canada published a policy brief that included our publication. And finally, Michael and I presented at Stanford University, building a culture of health equity and summit. And I do want to say that whole process that I've just spoke about, and we have to give credit to Dr. Kathleen Gartke, who is a senior medical officer at the Ottawa Hospital, who was unable to present today, but was a key stakeholder in having our position statement approved and helped with the writing of our publication and spreading our work across the country. And so, you know, we want to have more than a mission statement or more than a written policy. And we want to reevaluate our survey data to assess self-reported disability incidents at our institution. And you know, ideally, what we would like to do is perhaps have focus groups or somehow qualitatively but confidentially assess accommodation experiences using feedback from physicians with self-reported disabilities, and then determine any ongoing perceived barriers or inequitable opportunities. And we are pleased to say that last week, our accessibility and accommodations policy that was created by our working group at the Department of Medicine was recently improved. And that basically included the process of how a physician can ask for an accommodation, but also the process of what the leaders should be able to do to help accommodate, as well as some financial assistance from the divisions and the department. And we are also hoping to have some faculty development to educate about the accommodations process. And we're in the midst of hiring a person, the key person who can help with the accommodations and accessibility policy to action it, making sure that it remains in a confidential manner. Thank you. I don't know, Natalie, if at this point we're taking questions.
If we can just give Natalie a moment, she'll just be with us.
Okay, I can go ahead and read the first question.
That would be great. Thank you.
So the first question from an attendee says, my partner is a physician with a disability and they are finding a lot of stigma related to program director assuming something is related to a disability when it isn't, and limiting their job prospects. For example, dissuading them from working at their hospital site, etc. What recommendations do you have for helping reduce the culture of stigma in healthcare? Michael, do you want to start and then I can go ahead?
Sure, sure. That's a very good question, and obviously I'm sorry to hear your partner's going through that challenge. I think there's different approaches to this. I think a big part of it though is education around, incidents of disability, how many physicians have disabilities, all the types of disabilities out there, a bit more sort of normalizing of disability itself. And it may be more apparent to people like us who are in this field, but highlighting that with accommodations and disability, physicians can practice with the same quality when they are accommodated appropriately for the disabilities. Just to highlight how disability is common, disability doesn't impact quality of care, and some of those are less well known, I think. Additionally, I think hearing stories about physicians with disabilities who have had success and who are providing high quality care and are providing benefit to their institutions. I think the more we can do that, the better, in a way, to reduce stigma. And so, for example, there's initiatives in the US of that exactly, highlighting physicians with disabilities and highlighting success stories, as opposed to just the sort of historical thing about physicians with disabilities almost perceived as not as good as, or need to be helped, and sort of changing the narrative towards disability.
Yeah, and so just to add to that, what I found was really important is to find out who the stakeholders are at your work site. And at the hospital, I got to know the leadership very well, and then I have to say educated them to help them understand, because sometimes I would say even people don't know what a disability is, and they make assumptions about people with disabilities whether they're physical or you know what they vision in their head is not necessarily reality. And the second thing is once you're able to educate and help people understand that your institution or your group is a better group if there's diversity. And so right now in the Department of Medicine, on every job posting, there's a statement to say that we want physicians with disabilities to apply to any of the postings that are available. And the more inclusive your environment is, obviously you can help reduce the stigma, but it's a long road. You know, I think even people who have a friend who has a hearing impairment and she would not say she had a disability, because again, sometimes we have to educate ourselves as well.
So it's Natalie here. Sorry about missing the first question. We have another one here as well from Mebby Bell. Thank you both for the terrific presentations. I work in university accommodation services, and my child also has serious illness/disability and is in medical school. What strategies or advice would you have for addressing illness and disability in the residency matching process?
That's a really, really good question, and probably very, very difficult. I was part of a process with our particular division to help with a matching process for residency for fellows. And the questions that were originally being asked were so outdated that we revamped the entire questionnaire. I have never been part of a residency matching process, so I'm not sure if Dr. Kwan can answer a little bit better about strategies.
Yeah, it's obviously a really challenging situation that your child is in there. And I do sit on like an interviews for internal medicine residency applications. I can't speak, a lot to the admissions of it all, but I mean, I can speak to the fact that on interview questions, that's certainly not anything that would come up. It would be around their evaluations and their performance as a medical student, the quality of care that they're providing. And I'm not sure that it needs to be, I think it all depends on the situation in a way, but I'm not sure I can really provide much more direct advice for your child, but I would encourage them to reach out to the Canadian Association for Physicians with Disabilities. It's, as I mentioned in the presentation, there's a lot of medical students on there now. There's a lot of residents. I think, I only came to this lived experience of disability at the end of my residency, and I can't speak to it at all personally prior to that. But, all these medical students and residents, I think the connections could be made for them, and there are a lot of engaged people, learners in this space now, and they would be, I think, all interested in helping one another, answer some of these difficult questions. So it's online, or you could reach out to me directly if you want to contact.
Thank you so much. We've got another one here as well. Given the known issues of stigma, what is it that keeps the stigma alive? What can people, quote, not in charge end quote, do to break the stigma? We've been educating people for what feels like decades. Don't we have personal experience in this situation? And the person noted, I'd prefer care from someone who knows my pain personally. So some questions in there, perhaps more of a comment, wondering if either of you have thoughts.
There are a lot of great questions there. I'll just highlight the last one. That comment about preferring care from someone who knows your pain. I think that's a really valuable point you're mentioning, and I think it does speak to speaks to disability as a strength and as a asset rather than weakness. And it kind of goes back to the earlier question. I think if we can try to frame it like that, I think, you know, adding that learned experience and adding the tools to help with patient care, I think, you know, highlights some of the strengths of disability and challenges and resilience of practicing with a disability. And I wanted to just mention, there's a radiologist at Stanford, Peter Poulos. Anyway, he leads the disability for medical trainees at Stanford, and they're probably one of the top 2 or 3 institutions in terms of leadership in the States. And I've heard him say this a couple times, that, you know, if you hire a basketball coach, would you want somebody who would play basketball? And, you know, the answer is, of course, yes. And so, isn't it ironic that we don't look for physicians who have been patients? And that really hit home with me. Anyway, I wanted to just mention that. But Camille, please jump in for any of your other.
Yeah, I mean, if you look at other studies for other diverse groups, it shows that patients prefer to see a physician who can speak their language or who look like them, and this would be no different. I agree. You know, we've been educating people for decades, and again, to give an example, for women in medicine, you know, there are more than 50% of women in medical school now, and you look at our department and there's about 50% of women. Yet if you look at the leadership, there are very few women in the leadership positions. And I do think that, you know, unfortunately, the leadership makes a difference and sets the tone. And there are people in my group who are in the leadership positions who have never experienced what, you know, a person with a disability would have experienced, or a person of color who experiences racism. And unfortunately, there still is education, but not only that, it's actually being open to having people as your group, the diverse group. And so I always like to tell this story that I tell the leaders, that I had heard when I was speaking to each member of the medical advisory committee, who are department leaders of all the departments in the hospital. And this particular physician was from anesthesia. And he told me of a colleague of his who was legally blind, and his group accommodated him so that he was fully functional as an anesthetist in the operating room. And, you know, there are articles actually written about this gentleman, and anybody who hadn't heard this story was shocked that somebody who was legally blind could perform the procedures and job of an anesthetist in an OR. And so the best way I think in medicine to break the stigma is and have more people with disabilities as our colleagues who are able to work alongside of us and I personally think can give better care to patients when they understand what the patients are going through.
I'll add something really quickly. In my experience, you know, I've been doing this advocacy for about, I don't know, 5 years or so, and I think this is the time. You know, there is a lot of movement. You know, speaking optimistically, there's a lot more talk about wellness. There's a lot more talk about equity, diversity, and inclusion. Awareness is growing, interest is growing. You know, our work, as you saw earlier, was sort of shared extensively, you know, across the country. And so change is happening. I think we just need to keep at it and keep, you know, sharing with one another. And I think we're getting there. So hopefully we're kind of at the beginning of the changing tide.
Change in medicine is very, very slow. Sometimes I feel like we're the military. We're like the military.
Like turning a tanker around, hey? So I think we'll just do one last question here so that we can move on to our Indigenous closing. And this is from Allison Leblovic. What about the entrance requirements for medical school? I'm an accessibility advisor who works with students with disabilities, some of whom are trying to get into medical school. They are afraid to take even 4 courses instead of 5 to take their program more slowly. They fear they will be rejected before they are even considered, as they are not able to take a quote full end quote course load. These requirements seem to be inherently discriminatory. Any thoughts on this or how to change it?
I think unfortunately there are a lot of, you know, just the whole application towards medical school and you know, the MCAT exams and the accessibility of the interview process and everything. I think it's all. I'm not at all involved in this, but I know it's being talked a lot about among the EDI community, specifically whether, you know, course load is an impact on entrance requirements. Unfortunately, I can't speak directly to that. No, I don't know if you work with the medical school EDI group, right?
Yeah, I don't have so much experience with entrance requirements for medical school. I can tell you that I meet with a group of students from the University of Ottawa that have formed their own EDI committee where they address these kind of issues as well as currently while they're in medical school. And they are very knowledgeable and active in change so that even what they're doing while they're in medical school is equitable and fair for each other. I actually am really proud of the group. They've come up with their own policy of inclusivity and actually even made a separate document, which I don't think is completed yet, but for medical students with disabilities and how they can access support without I guess the stigma of trying to get support. So they have a document to help students navigate the system while they're in medical school.
Thank you both so much. Very, very much appreciating the care, time, and conscientiousness and just expertise in this presentation, and also for sharing your personal story, Dr. Kwan. This was great. So thank you so much. We are going to move into our next portion here, which is the penultimate, which I've learned means second to last. I've been using that word incorrectly for some time now, but we are going to now have an Indigenous closing and reflection with Vern Ross, and I would just like to introduce Vern properly. Just give me one moment. Just pulling it up here. Vern Ross is from Cote First Nation, a Saulteaux nation belonging to Treaty 4 in Saskatchewan. He has always worked with traditional healers and language interpreters. Vern is not an elder, however, he works with elders' guidance and is one of the traditional knowledge keepers. Vern holds a BA in Indigenous Studies and a Master of Social Work. Currently in a PhD, his research focus is Two-Spirited People. He has also taught several courses at the Center for Indigenous Studies, department at UofT. Vern continues to be a social worker, teacher, and mentor for students from all walks of life. And it's my pleasure to welcome you here to this space, Vern. Thank you.
Chimi, great. Are you able to hear me?
Yes.
Okay, thank you very much. And I'm going to light up the smudge bowl again and light up the one of the sacred four medicines, which is the sage. And so and to give us all that nurturing and blessing to send us off in a good way. We never say goodbye. We always say kiwapamin, which means I'll see you again. And I'm sure that we will all cross paths with each other during our own travels. But one of the things that I wanted to share with you is before I do the closing here is that I've had the opportunity of working in hospitals myself way back in the late 80s and part of the early 90s, and really it was about advocating for my people that were coming through the emergency department. And within that, my work in those hospitals in Regina, it was very challenging. And it was really about access to medical care and to strongly to speak on their behalf and to break down that the medical terminology that we hear and we experience a lot when we enter these hospitals. And sometimes that can be a very, it is a barrier for one, and it can be stressful and frightening for ones that don't know like what's going on. And my role was to provide that bridge that communication between all the families and patients and all the children and grandparents to all medical staff and the nurses, and it took some lot of cross-cultural education to make this happen, and you continue to build these relationships up, because that's really important to do that, because we're all striving to work together within my role, I just didn't only work in one department, the emergency department. I worked my way all the way right through to intensive care unit, cardiology, and children's ward, and then dealing with other medical social workers in the hospital as well as outside the hospital. And certainly I had to work with ones that had disabilities, whether it was a physical or emotional or spiritual and a mental, because we worked holistically, and to work with all those four components, it was really important that we try to balance those things, and it was not easy. And this is why it was always important to have an elder in present, language interpreters, because they really help to knock down some of those barriers when it comes to access, and to really to work with the patients to give them hope, and to kind of take them out from that stress and that fear. And many of us all know that when working in hospital, it's kind of like a little city of its own. It has its own community and its own life in there. And but when you come right in as a patient, whatever, then that's where your work begins. And it's the same thing, even in universities here. When I began working with students with disabilities, again, it's not just the physical, but it's also with learning, and it's also with spiritual and mental, and because my background is in social work, I'm very honored to actually to put those into practice. And I have a very special friend who has cerebral palsy, and I've worked with him for about 20 years. And when I first met him, he was one who did not have much confidence, and he was struggling. And to give him that support, that guidance, and learning to speak up, teach him how to speak up for himself, and without being afraid or being told that you're not accepted, or you don't belong here, and that. And it took many years to teach him, provide him some tools of not being afraid to ask questions, and having that confidence and believe in yourself. And today, my friend has come such a long way. He's now working on his second master's degree and wants to pursue a PhD. He's built a strong relationship with the university and with many professors. And I'm very proud of him, because he now, helps others. He gets involved, and that's what keeps him going. And so, but at the same time, when you're working with students with disabilities, and trying to create some sort of access for them, it's really important to build that relationship up without being this power or authority, having this authority and everything. And I always tell them, that that's not how I operate, that's not how I work. And so having to have said that, is really, I work with inclusion rather than the opposite, exclusion. And I'm very honored to continue to keep working that in a good way, and to help my students, and to even social work is really, you know, no matter where you go, you'll always come across, you're wearing your hat, your social work hat, wherever you go. You just don't, you know, you just don't take it off. It keeps coming off and on, I would have to say, you know, but at the same time, you have to do a lot of self-care for yourself. That's really important. So by having to say all of that, I'm going to do a closing here by saying that Creator, I'd like to say Chimi Gwech, and give thanks to our grandmothers and our grandfather who sit in all of the 4 directions. We thank them for all their teachings and guidance and knowledge that we so cherish and value. And Creator, we give thanks to all our sacred medicines that have so much personal meanings to us as an Indigenous people. And as we leave here today, that we continue to ask for your guidance and strength to help us to work together in a good way. And also to continue to listen to the stories that are shared with us by either from our students, our patients, our families, our friends, our guest speakers, our teachers, our social workers, our doctors, our nurses. Those are so important. And then I want to also to say, Greater, is that when we do leave here, is that everyone here have a safe and a wonderful journey home to their loved ones and families. And don't forget to hug those little ones that are waiting for you at home. So I just want to acknowledge the 4 directions by saying Chimi Gwech, Chimi Gwech, Chimi Gwech, Chimi Gwech. Thank you. Thank you, Natalie.
Thank you, Vern. Mike, you're muted.
Pandemic things I still haven't learned to do. Good afternoon, everyone. My name's Mike Nicholson, and I serve as the director for the University of Toronto Accessibility Services Office. We're a team of over 40 staff, supporting close to 6,000 students across a range of graduate, undergraduate, and professional programs. I identify as a white cisgender male, use the pronouns he, him, his, and am a settler on Turtle Island. I recently celebrated what I would call the 13th anniversary of my 30th birthday and have short cut brown hair with a brown beard. I'm wearing a light blue checkered shirt and have a background, a rural background in my Zoom background from where I grew up around Lindsay, Ontario. I do hope you could stay for a few short minutes. I did want to convey a special note of thanks to several groups of individuals who made today happen. I promise these remarks won't be too long because I do appreciate I am the only thing standing between many of you and your weekend that's about to be here, so I will keep it short and brief. First of all, I wanted to thank all of you who've decided to join us over the course of the last 3 days. We know our work is very overwhelming, especially since the emergence of COVID and the pandemic, and that taking time away to learn, discuss, and reflect is an incredible challenge in our work. And in fact, it's almost impossible some days. The fact you've created protective time in your busy lives to join your colleagues in furthering and deepening our knowledge in this work deserves recognition and special acknowledgement. You've joined close to 600 people from across Canada, North America, and the Caribbean with us over the last 3 days, representing people working both inside and outside post-secondary. And again, thank you for being here. In an effort to ensure cost is not a barrier to our gathering and learning, we've been able to keep this conference free of charge and available to anyone from inside or outside post-secondary who shares in our commitment to inclusive learning and affecting meaningful change. In order to accomplish this, we're incredibly fortunate that those who have made this conference happen share our goals, and because of this have donated their time, energy, skills, and talent, either without financial compensation or at a dramatically reduced rate that does not represent the value of their true work or their contributions. To all of these people, we say thank you. The conference represents a combined effort of over 150 people working to plan, organize, put in place logistics, and produce content over the course of the last 12 months. My thanks to all of these 150 people, whether you were presenters, interpreters, captioners, panel organizers, Indigenous knowledge keepers, or any one of the number of people who had very specific and special roles today. We've been incredibly fortunate for the contributions you've made over the last 3 days and in the time and talents you've given us. Please take a moment to reflect on the fact that because of your efforts here, there are multiple individuals living with disability-related barriers whose lives will be changed immeasurably because somebody at this conference in the last 3 days has learned a new practice, acquired a new skill, been given a new way of thinking and approaching a subject, and because of that have exactly the right intervention at the right time that will change the trajectory of an individual's life. This is a credit to all of you who've given so much of your time and energy to the conference and shared your talents, and a reflection of how critical this work is and how much it matters. Some specific thanks I really did want, I can't name 150 people, unfortunately, but did want to name a few people very specifically. Fernemi Okanami, Blake Charlton, and Kevin Stoddart are keynote speakers. The Honorable Carla Qualtrough, Federal Minister of Employment and Workforce Development, as well as Alex Fernandez working in her office. Sari Springer, who is just such a special friend to the office and an ally in our work, always there to support us, and this year was no different. And we really thank Sari for coming and making her contributions. Heather Kelly and Sandy Welsh, both for speaking at the conference and giving special addresses, but also their special encouragement in the project of keeping this conference going every year. Vern, thank you for coming and sharing your knowledge as a traditional knowledge keeper. And a special note of thanks to Michael White as well at UofT First Nations House, who referred us to you and was very eager to support us in incorporating Indigenous perspectives and presence into this conference. Want to thank, of course, as well our sign language interpreters, specifically Anna Grunfeld and Marcia Adolfi Martins. You have been here beginning to end, and really can only imagine how tired you have been. You must be after the end of this conference and all the work you have done. But thank you for being here for every session and really showing what a great commitment to accessibility inclusion we can have. The Faculty of Medicine, I want to thank a few faculties and departments across the university. First of all, Faculty of Medicine and Dr. Tony Pignatello, again, a really great friend and ally in our office, and somebody we work with really closely and depend on. Thank you, Tony, for all of your help. Faculty of Social Work, Kevin Stoddart and Charmaine Williams. The Department of Occupational Therapy, Jill Steer, who is going to be retiring shortly, but who has been an incredible ally and supporter in our work over the last few years, and just a wonderful human being. Donna Barker and Baden Nurazi-Kia, who's also quickly becoming a great friend and ally of our office. Faculty of Information Studies, Joanna Lau, Maliana Bernstein. We wish Stephanie Rose, who participated as well, all the best in her future outside of UofT. And Wendy Duff, the Dean at the Faculty of Information Studies, who I wish I could carbon copy and reproduce all over this university. She is a tremendous, tremendous ally on the academic side in terms of this work. And I hope you saw in her presentation or their presentation around UDL just what a force of nature she has been in affecting change in a very short period of time in her division. Department of Physical Therapy, Jamie Coleman, working with us on a special presentation. UofT AODA office, Ben Poynton. Center for Teaching Support and Innovation, Michael Kasparak. And as well, of course, the entire accessibility services team. There's literally not one individual in our office who didn't contribute in some way to making today happen. Wanting especially to thank Reshma Drodia, Irene Sullivan, Michelle Morgani, Blake Porter, Ann Thomas, Morgan Brett, and Janelle Anderson, who presented and organized panels. and Sarah Lerner, who organized sign language interpreting and real-time captioning support. I want to thank the students whose voice we've tried to ensure are heard and are front and center at this conference and in our work, including Jessica Chekhov, Olivia Wallace, Lauren LeBlanc, and Fatima Hassan. I want to recognize Tina Doyle, the director for UofT Scarborough, and Elizabeth Martin, UofT Mississauga, for their encouragement of this conference and their financial contributions, which specifically helped us to ensure sign language interpreters for all of these sessions. Boris Vukovic at Carleton University and the entire Canada Accessibility Network, I want to thank them for their contributions and for their support of this conference. Franco Guido, who we've worked with very, very closely over the last while, John Santiago, and Alex Worden of the UofT Campus Events team, thank you so much for all your behind the scenes work on the Zoom platform and making things happen so seamlessly for our presenters and participants. Student Life Communications Office, particularly Anthony Bowman, Tricia Kenderdine, and Chantal Duchesne for all of their work with their website support and communications and registration. Jason Bromett for Microsoft Canada, who's become a quick friend of the office and really has provided some very different perspectives on accessibility and inclusion from the private sector that were really special at this conference. And finally, Dr. Michael Kwan and Dr. Camille Monroe. My last couple points quickly, but really importantly, I want to give a very, very, very special thank you to my two partners in our small but mighty organizing committee for this conference, Dr. Pearl Levy and Natalie Roach, who you've seen throughout the course of this conference. Pearl's incredible knowledge base and experience with post-secondary disability over the course of the last 30 years has been brought to bear on every aspect of this conference. And through so many hours of her time and the ideas and creativity she has brought forward and finding individual speakers and in brainstorming specific sessions, she's really applied this knowledge to great effect. From the bottom of my heart, Pearl, I can't thank you enough for what you've done and can't thank you enough and appreciate you enough for the privilege for having worked with you. To Natalie Roach, who's one of our two very talented assistant directors in my office, you've again created miracles and made magic happen this year with pulling this all off so flawlessly. I have never met someone with as much ability to manage extensive detail, logistics, and complexity without error, and all the while patiently listening to me every day come up with the ideas each morning that I had in the middle of the night. And sometimes when they're good ideas, making them happen, and other times making them disappear. But thank you, Natalie, for everything you do and for all of the support. It's just, can't thank you enough again. Lastly, planning for this conference started immediately after the close of our last conference in June 2021, and session topics were planned and developed based on post-conference survey suggestions we were provided last year. So please, when you get the survey in the next couple of weeks, please fill it out. We really do look carefully at each and every comment and think about it and consider how we could implement what you are considering to be the type of information or supports that would make your work better and stronger. So please let us know what you're looking for, what you're thinking of, and let us know about this conference. What was good, what was bad, and what was anything in between. We look forward to working, learning, and collaborating with you all soon. Thank you so much.
And that's it, everyone. Have a great weekend, and thank you so much. Bye.